programs, and I was really surprised to know that we have crossed 23,000 registrations. I mean, I cannot be very certain about the number of people logged in, but then what was very pleasing and amazing was in the research methodology workshop, we had a login of numbers of something like plus 1,400. And this was a welcome change to the meeting that we had a few years ago. So it meaning that, well, it augurs very well for the Cardiovascular Society and the Cardiological Society of India that people are research oriented every day. Yesterday we had an excellent academic program, except for a very brief technical snack, which was not in our hand. Everything was perfect. We kept the time, the speakers, the chairpersons, the hall managers, anchors. A big thank to each one of you. And I'm sure we will have a similar strictness of time, because absolutely every one of you know that in a virtual meeting, it's absolutely important that we keep the time. Well, today we had again an array of sessions, exciting sessions, passionate session. We are starting with the number games of hypertension in Sabarmathi and all the others. Simultaneously, we will have all the three halls running. The highlights possibly of today's will be by 11:30 we have the quiz, the national quiz, intercollegiate quiz final coming up with the 4 teams and vying very passionately and vigorously, testing the skill of their quiz masters. So that is something which I don't think any one of you will miss. And then, of course, we have ACC CSI session, then a TAVR symposia, an imaging session. Many of the international guests come and give their lectures toward the end of the day. What my request again to the dear delegates will be, try to be a little more interactive. I know there are some technical difficulties in hitting the chat box for everyone, but then it will be good if you interact so that the chairperson possibly can pick up your queries and interact with the experts and the speakers. Also, make use of the polls during the debate session. Again, that will give a very healthy, for the debaters, it will be very nice to know, even for the chairperson, it will be nice to know what you people think about the hot debates. And mind you, we have very heated up debates coming today. So that will be all from the scientific chairman's desk. We're going to have a fantastic day. All the very best. Go ahead.
All the very best to Dr. Mohanan.
Thank you, Dr. Gupta.
It's a marvelous meeting.
Now we request the chairpersons to take over, sir, for the session. Chairpersons, are you ready? Yes, sir, you are audible, sir.
Okay. Shall we start?
We are ready, sir. The first speaker is ready. Dr. Oni, you could start sharing your screen, please. And you're still muted. Okay, now you release the mute. Can you start sharing, please?
Okay, dear all, and we will start the session. The first talk is on nutrition, salt, and hypertension, which will be delivered by Dr. Govindan Unni. Dr. Govindan Unni, please.
Good morning, everyone. I hope I am audible. I hope I am audible.
Yeah.
Yes, Dr. Unni.
morning, everybody. The second day of CSI 2020 in Ahmedabad starts nutrition, salt, and hypertension. Let me first of all take you to some new concepts regarding sodium handling and interaction in numerous organs. Now, as you know, kidney is the major organ for sodium excretion. Of course, there may be some small amount excreted through the sweat, but kidney is the major organ for sodium excretion. The current theory is that the plasma sodium concentration and the tissue sodium concentration equilibrates, with the result that kidneys can control total body sodium content. Kidneys control the plasma sodium, and since it equilibrates with the tissue sodium, kidneys are able to control the total body sodium content. That is the current concepts. Now it is slowly getting changed. The plasma sodium concentrations are stable, no doubt about that, but the body sodium content is not always constant. This is because there are reservoirs in the body which store and release sodium inside the body. And two of the major reservoirs are the skin and muscle. And we find that men have higher skin sodium concentration than women. Probably the reason why men have more prevalence of hypertension, and also the elderly have more skin sodium storage. Again, explaining the reasons why elderly are more prone to hypertension. Now, when you take large amounts of salt, high salt intake, it induces sodium accumulation in the skin. And this is independent of the circulating sodium concentration, because the circulating sodium concentration, as you know, is controlled by the kidney. Now, this high accumulation of salt in the skin stimulates monocytes and macrophages to secrete a vascular endothelial growth factor C, which is a major lymphangiogenic growth factor, which means it stimulates cutaneous lymphatic production. And these lymphatics clear the sodium from the skin to the plasma, and then, of course, by the kidney through the urine. And so, if we have some inhibition of this VEGF-C pathway, that can cause excessive salt accumulation in the skin and leads to high blood pressure. In fact, there are people now who are researching on pharmacological modification of skin lymph vessels and homeostatic immune cells, and these may become novel therapeutic targets to prevent skin barrier dysfunction and thereby treat hypertension and cardiovascular disease in the future. Well, we always talk about sodium, but don't forget that chloride is also an important osmolyte in plasma and tissues. Let me now talk to you about another recently accepted concept, which is known as the natriuretic ureotelic regulation. Now, this was detected in the Mars travelers. Actually, these are not travelers to Mars, but these are travelers in a Mars simulated travel. The advantage is that their food can be exactly calculated and their salt intake can also be exactly calculated. So these Mars travelers were studied at 3 levels of salt intake, 12, 9, and 6 grams of salt per day. They were studied for 105 to 205 days with salt intake of 12 gram intake, and then it was reduced within months to 6 grams. Surprisingly, it was found that even when salt intake is the same, the urinary sodium excretion daily exhibited huge variability, telling us thereby that a single 24-hour urinary sodium excretion could not tally with daily salt intake. This is important because so far most of our epidemiological studies on salt and hypertension have taken 24-hour urinary sodium excretion as a marker of daily salt intake. This now we know is wrong. Now, again, another surprising finding was that the high salt intake did not increase urine volume. In fact, significant amount of water was reabsorbed at the kidney and the salt was concentrated in the urine. So there is a difference between short-term and long-term response to salt excretion. In the short term, as you take more salt, salt and water are excreted in the urine. Whereas in the long term, the kidney concentrates the urine and so salt is excreted, but water is not excreted. This is because the high salt intake induces urea transporter 1, which drives urea accumulation in renal medulla. Urea accumulates in the renal medulla, the osmolality of the renal medulla increases, and hence water is reabsorbed. In other words, the accumulated urea in the renal medulla acts as an osmotic driving force against the diuresis that is produced by sodium. So it acts as anti-diuresis, counterbalancing the sodium-driven effect. Now, we all believe that a high salt diet makes us thirsty. However, the Mars study showed that a 6-gram increase in salt intake actually reduced 24-hour fluid intake, and 12-gram day salt diet actually made subjects hungry. This is again because of the natriuretic urotelic regulation, where natriuresis is counterbalanced by increased urea in the renal medulla. And this increased urea is produced by liver, which is very energy intensive. So there is a catabolic state because liver steals the energy, so-called steals the energy from the muscle. And so there is a catabolic state which increases the appetites. So a high salt intake switches liver energy metabolism from the energy intensive gluconeogenesis to ketogenesis. And the high salt ingestion also induces a catabolic state, producing protein wasting in the muscles and ketogenesis in the liver. All these increase appetite and produces overeating, which when continued for a long time leads to obesity and metabolic syndrome. So now we know salt intake also leads to obesity and metabolic syndrome in the long term. The basic principle underlying all this is the human body's urge to conserve water. This can be traced to the evolution because life on earth started in water and all living organisms require water to survive. And so when life shifted from sea to the ground, from the sea where it was surrounded by water to the ground where there was no water, the basic essential factor in the human body, or in fact all terrestrial bodies, is to retain water. And so kidneys filter 180 liter volume of blood per day, but reabsorb 99%. Similarly, when you take excess dietary salt and it induces natriuresis, there is a water loss, and this is counterbalanced, as I already described, by the urea-driven water conservation system. Now we know the magnitude of the decrease with sodium reduction is greater in older populations, non-white population, and those with a higher blood pressure. This relationship between BP decrease and sodium reduction becomes weaker as the blood pressure comes down. We also know that if you dramatically reduce sodium intake, it can lead to a compensatory increase in the RAS system as well as the sympathetic nervous system and may increase the blood pressure, or ironically may increase the blood pressure. So there are a lot of things which we need further studies. The effect of salt restriction in patients without hypertension, the effect of dramatically reducing sodium intake. Till then, the U-shaped or J-shaped curve may be explained by so many of these things. And so it is still a controversy whether there is really a U-shaped or a J-shaped curve. Now, don't forget potassium, because the problems of increased sodium intake can be counterbalanced by increasing the potassium intake. In the pre-industrial era, diets contain potassium on approximately 200 millimoles per day. But in the modern day, food processing has become important, and food processing reduces the potassium content of the foods. In fact, diet high in processed foods and low in fresh fruits and vegetables, which is the 21st century diet, lack potassium also. Well, there is this question also, are we barking up the wrong white crystal? What about the other white crystal, that is sugar? Is it salt and sugar or salt or sugar? So a word about sugar sweetened beverages, or SSBs. Increased sugar intake, particularly if maintained for more than 8 weeks, increases blood pressure. It also leads to increased sodium absorption. So there is a relationship between the two also. Moreover, high fructose intake activates the RAS system as well as the sympathetic nervous system. In fact, each additional serving of SSB per day increases the risk of hypertension by 8%. Similarly, reduction in SSB is associated with a lower BP in the long term, both systolic and diastolic blood pressure. Coming to diet now, from salt, potassium, sugar to diet, we know DASH diet is the most effective approach for the management of hypertension, especially if it's combined with calorie restriction. And probably equally important or equally good is the Mediterranean diet, which contains fresh fruits, vegetables, legumes, whole grains, olives, nuts, and seeds, and extra virgin olive oil. That is one of the differences between Mediterranean diet and DASH diet. The Mediterranean contains also extra virgin olive oil. Frequent consumption of fish and moderate consumption of dietary products and red wine. That is yet another difference between DASH diet and Mediterranean diet, the importance of red wine. And of course, low consumption of red meat and isolated sugars. Now, before concluding, let me go to another important aspect, which is again now being increasingly described in probably all diseases, not just hypertension and cardiovascular diseases, the role of gut microbiota. Gastrointestinal tract houses the largest number of immune cells in our body. And these immune cells have a great role in the production and development of experimental hypertension. So gut microbiota can protect or promote the development of experimental hypertension. And diet is one of the major modulators of the gut microbiota. So that is another important concept, that changing the diet will change the gut microbiota and thus either protect or promote development of experimental hypertension. Diets that emphasize high fiber intake, like what we already saw, the Mediterranean diet and the DASH diet, promote expansion of protective microbes. And these protective microbes release gut metabolites such as short chain fatty acids, which are immune, BP, and cardioprotective. Whereas diets lacking in fiber or high in salt and fat, like the Western diet, reduce the prevalence of commensal microbial species, and these in turn support a pathogenic and pro-inflammatory environment. So to conclude, ladies and gentlemen, salt nutrition and hypertension is improving. There are a lot of new concepts coming in the salt handling in the body. There are a lot of new concepts in the management of gut microbiota. With respect to diet and potassium, I'm sure all of you are very familiar with it. So the message I want to give in this talk are: one, the new concepts regarding sodium metabolism in the body, and two, with regard to the importance of gut microbiota in the production of hypertension and cardiovascular disease. Thank you very much.
Koshe, doctor, unmute and speak. Dr. Koshe, kindly unmute. Hello, good morning, Dr. Gupta sir. Are you able to hear?
Yes, just 1 minute. I think there's some.
Dr. Koshe, kindly unmute and.
Good morning, Sangram.
Good morning, sir.
Am I audible now?
Yes, sir. Yes, sir.
Yeah. I mean, is Dr. Padmanabhan there? Dr. Santosh? The co-chairpersons? Okay. And if they are not there, I mean, we will go on to the next topic. And it is on mass hypertension. Is it too much stress? This will be presented by Dr. S.P. Gupta. Dr. S.P. Gupta, sir.
Yes, Dr. Gupta. No, don't, Dr. Gupta. You have a reverse arrow at the top left. Please click on the reverse arrow. Top left. Yes.
Yeah.
Right. Now go to slideshow, sir. And you're ready to go, sir. Please go ahead.
Yeah. Thank you very much. First of all, I would like to thank Dr. Mohanan for inviting me to deliver this talk on mass hypertension. Is it too much stress? Basically, since the advent of ambulatory BP monitoring, we have come to know the 4 categories of hypertension. One is the normal blood pressure, where the office blood pressure or the clinic blood pressure and the home or out of office blood pressure both are normal. Then we have got sustained hypertension, where both office BP as well as out of the office BP both are high. And then I think we know very clearly about white coat hypertension, where the home blood pressure is normal, but the clinic blood pressure is high. And now we have come to know there is a reverse thing, where the office blood pressure or the clinic blood pressure is normal, but the out of office or the home blood pressure is high. That is called as mass hypertension. This mass hypertension is an emerging clinical entity which is under-recognized with under-recognized prevalence, and it has got a lot of increased cardiovascular morbidity and mortality. The frequency of mass hypertension is high in individuals where people are diabetic or they are having chronic kidney disease. And I think it's very important to identify mass hypertension early, because we can prevent cardiovascular morbidity and mortality by recognizing this identity. A self-home monitoring of blood pressure and use of ABPM or ambulatory BP monitoring is the gold standard for detection and prognostic implications. Masked hypertension has been categorized by defining it that the office blood pressure is normal, which is less than 140/90, but the ambulatory or home BP readings are high in the hypertensive range. This is the definition of masked hypertension. Basically, there are few categories of people where we must suspect a masked hypertension, especially in the young man, elderly patients with increased BP variability, patients with diabetes or kidney disease, or transiently elevated blood pressure, especially people who are in pre-hypertension category. There we must suspect masked hypertension. Patients with unfavorable health lifestyle, like people who are smoker or who are obese with less activity, or people who are taking excess of alcohol. And I have mentioned that pre-hypertension is one category where we must suspect masked hypertension. Patients who are at high cardiovascular risk, or patient of shortened sleep time or of OSA, obstructive sleep apnea, there is high prevalence of masked hypertension. These are the definition of ABPM or home blood pressure regarding the daytime blood pressure, which is normal as 135/85 for both ABPM and home blood pressure monitoring, while the nighttime blood pressure is normal is less than 120/70, and 24 hours ABPM is less than 130/80. More than that will be called as elevated blood pressure in normal or home settings. About 1 in 7 to 8 persons with normal office BP will be having masked hypertension. So it's quite a high prevalence. And if we go into the different studies, the prevalence has been categorized is almost 8 to 20% amongst untreated adults, and almost up to the 60% among the people who have been treated for hypertension. So in treatment group, the prevalence of masked hypertension is very high. Among children and adolescents also, it is the prevalence is almost 7.4 to 11%, and it is thought to be a precursor of sustained hypertension. There is one study of 11-country IDACO report, which is an international database on ambulatory monitoring for cardiovascular outcomes, where they have taken people more than 60, mean age of more than 64 years, and they have seen the daytime ABPM, almost 1,100 patients, and out of that, about 27% people had sustained hypertension, almost 1/3 had white coat hypertension, and almost half of them had masked hypertension. Masked hypertension in normotensive group was around 9% by definition of ISH. Another report of the same IDACO report of 9,691 non-diabetic people, almost 18.8% when people had untreated, and in the treatment group, the prevalence of masked hypertension was 30%. In diabetic patient, in untreated group, the masked hypertension was about 30%, and in the treatment group, it was around 42%. So you can see the prevalence of masked hypertension is pretty high. It's the same thing about masked hypertension prevalence in non-diabetic and diabetic group, which I have talked in the last slide. In chronic kidney disease also, the masked hypertension is quite common. LVH is 4 times more frequent in the presence of masked hypertension. Nearly 60% of the treated patients with CKD had masked hypertension. The prevalence of masked uncontrolled hypertension is present in 66% in patients with high or normal clinic systolic blood pressure, and almost 1/3 in normal clinic systolic blood pressure, and 17% with optimal clinic systolic blood pressure. Thus, patients with CKD and pre-hypertension warrant ambulatory BP monitoring to identify masked uncontrolled hypertension. People have talked which is better, whether home blood pressure monitoring is better or ambulatory BP monitoring is better. There is one study which came out in 2008, which said that, that there's no statistical difference between the prevalence of masked hypertension as determined by either home blood pressure monitoring or by ABPM. But there is a definite advantage of ABPM over home blood pressure monitoring, that it identifies patients with normal daytime but nocturnal high blood pressure. In addition, the ABPM readings are taken during normal activity, where home blood pressure monitoring are always taken at rest. There has been a prognostic significance of masked hypertension. We know that all cardiovascular events in this EDECO study of approximately 7,000 people, and there is another study of CHEF study of systolic hypertension in elderly patient for assessment and follow-up, where the white coat hypertension, the hazard ratio of all cardiovascular events in the EDECO study was 1.22, while in CHEF study it was 1.18. In masked hypertension, the hazard ratio of cardiovascular events was 1.62, almost 1.5 times more. And in the CHEF study, it was 2.06. While in sustained hypertension, the hazard ratio was 1.80 in EDECO and 1.96 in CHEF study. There's another study, Ohasama study of more than 1,000 people aged 40 years and older. The composite risk of CV mortality and stroke morbidity was seen, and the hazard ratio was in masked hypertension was 2.13 in masked hypertension, and in sustained hypertension is was 2.26. So why is the prevalence of masked uncontrolled hypertension higher in treated versus untreated patient? We have seen that in untreated patient, the prevalence is slightly lower as compared to the treated patient. Maybe the patient are non-compliant with medication, and we try to aim that the out of office BP is not thought of. We try to normalize the office blood pressure, and we forget about the out of office blood pressure. These are certain studies which are showing the CV events as far as masked hypertension is concerned. If we take compared to normotension, in pre-hypertension, the hazard ratio is 1.36, while in masked hypertension is almost 2 times 2.11, and in sustained hypertension is 2.08 as far as CV events. So CV events are quite high in masked hypertension. It's almost equal to sustained hypertension. Similarly, we see the stroke in masked hypertension, the stroke is almost 3 times of the normotension and is almost comparable to sustained hypertension, whereas it's 2.97. So masked hypertension, if we talk of the target organ damage, there is higher left ventricular mass index, and left ventricular hypertrophy is high in masked hypertension, as well as the CIMT is high in masked hypertension, and it's quite comparable to sustained hypertension, or it may have the intermediate values as compared to true normotensive or sustained hypertension. In one study, the left ventricular mass index was 73 gram in normotensive, 86 gram in masked hypertension, and 90 grams in sustained hypertension. The carotid plaque was 15% in normotensive, and in almost 28% in masked hypertension and sustained hypertension. And the prevalence of microalbuminuria is also high in masked hypertension, as well as the pulse wave velocity, which is a parameter for arterial stiffness, is higher in masked hypertension. And if we want to see whether if we control masked hypertension, whether there is a regression. So yes, there is one study of a regression of target organ damage on effective control of blood pressure in 80 non-diabetic hypertensive patient. Follow-up was of 30 months, where they have achieved a good out-of-office BP control as well as the clinic BP control. And the left ventricular mass index decreased from 117 to 95. The LVH decreased from 45% to almost 20%. And the microalbuminuria also decreased from 14% to almost 4%. And this is showing the increased cardiovascular risk and masked uncontrolled hypertension, where the masked uncontrolled hypertension, there is whether we are talking of masked hypertension in treated group or untreated group, and both the cardiovascular risk is much high if it's uncontrolled masked hypertension in treated group. So diagnostic strategies for masked hypertension, meta-analysis concluded that neither office or nor HBPM, the home blood pressure monitoring, is sufficient, have got sufficient sensitivity nor specificity to replace ABPM reference standard. I have talked about the ABPM because it can diagnose nocturnal masked hypertension, as well as ABPM readings are taken during normal activity. So consequently, it has been recommended that hypertension be confirmed by EBPM before commencing antihypertensive therapy. And this is one study which has come just in November 2020, where they've shown that the reproducibility of mask hypertension with one reading is not sufficient. So they recommend that second reading to confirm mask hypertension is mandatory. And this is the screening, how to screen people. If the people are of normotensive, then we don't do anything. If they are of pre-hypertension group, then we do ambulatory BP monitoring. If they are normal, then we just leave them alone. Or if they are high, then we term them as mask hypertension. And similarly, if the BP is on the higher side, we try to monitor either home blood pressure or ambulatory BP monitoring, and try to confirm the BP monitoring by two readings, two BPM readings before we treat these patients. So we have to ensure optimal antihypertensive management. We try to select long-acting antihypertensive medication. Whether we should try to manage mask hypertension treatment by HBPM. So take-home messages are the prevalence of mask hypertension in patients with treated group with controlled clinic BP is high. Microhypertension is more common in patients with CKD, and it is more associated with proteinuria and cardiovascular target organ damage. Nocturnal BP is increasingly recognized as a strong predictor in many studies of ABPM. Similarly, the clinic BP monitoring alone is not adequate to optimize BP control because many people have elevated nocturnal BP. And US Preventive Services Task Force concluded that ABPM should be the diagnostic method of choice for detecting both outliers of white coat hypertension and mask hypertension. Thank you very much.
Thank you, Dr. Gupta, for the excellent speech on this particular subject, the specific phenotype of hypertension, masked hypertension. Now, I just want to know whether
I have to stop sharing. How to stop sharing? It's okay?
Yes, sir. You
Okay.
stop.
I just want to know whether Dr. Padmanabhan or Dr. Santosh are there, the co-chairpersons. Dr. James, Dr. Prashant, Dr. Sangram, anyone of you?
Yeah, I am here. Dr. Sangram Biral.
Okay, Sangram, why don't you just take, be a chairperson and, take on the next topic.
Yeah, the questions we will be taking at the end in the discussion.
That's right, and we'll be taking at the end of the 3 session.
So now I request Dr. A. Muruganathan to speak on strategies to increase awareness of hypertension in India. Over to you, Dr. Muruganathan, sir.
Okay. Is the screen visible, Sangram?
Yes, sir, yes.
I'll make it a big slide, a big screen. Okay.
Yeah.
Okay. Thank you very much. At the outset, I must thank Dr. Mohanan and the other scientific committee members for giving me this opportunity. I feel my topic, strategies to increase awareness of hypertension in India, is the most important topic, a public health topic. I think it is the most important topic of the CSI today, because this is what everybody should know and everybody should implement. If you don't know mitral stenosis treatment, doesn't matter, but at least these are the things which you can implement in your practice and can give the country a very important aspect of relieving the burden of hypertension. Okay, now, why it is important to have awareness of hypertension? Always awareness means awareness will lead to awakening. Awakening leads to action. Action leads to prevention. So hypertension can be prevented. Early detection can prevent complications. Because if you see, high blood pressure is the most attributable risk for deaths all over the world, especially in India. And this is, I call it as hemodynamic malignancy, as Venkatraman says. It can produce coronary heart disease, it can produce retinopathy, it can produce stroke, it can produce cerebral hemorrhage, kidney failure, etc. India, more people with hypertension than any other country. If you see 200 million people, that means 20 crores of people are having hypertension in India compared to other countries. And this is the prevalence of hypertension in various Indian states according to DLHS 4 survey study. So Sikkim stands first. And the WHL, the recommended public health actions for National Hypertension Organization, what do they recommend? They say Increase awareness that hypertension is largely preventable. Increase awareness that hypertension is largely caused by unhealthy eating, especially high dietary salt. Increase awareness that hypertension can be inexpensively and easily detected and managed. So all the association should create awareness. That is what WHL says. WHL, all of you know, is a charitable organization comprised of national and regional hypertension societies. If you see the original research article in American Heart Association 2020, which says education is considered as an important aspect, but unfortunately in India, rural India, it is not happening. So you'll have to bury the discussion and investigation about it. And in the Pure study also say hypertension in India, awareness is very low. In the PLAS Medicine, an article in 2019 has come, hypertension screening awareness between 15 to 49 years. They say the proportion of adults with hypertension are very high, but the awareness of the diagnosis is very low, especially in the rural area, importantly among men and women. What is the burden of hypertension? I already told you, 20 crore people, 1/3 of the Indian patients have raised blood pressure, 25% of the rural and 42% of the urban are aware, but 25% and 38% of the urban only are treated, and out of which 1/10 of the rural and 1/5 of the urban only control. And you know, we all used to say the rule of halves. Only half have been diagnosed. In the half, only those diagnosed have been treated. Only half those treated are adequately controlled. That's only 12.5 overall are adequately controlled. And this is a India Hypertension Control Management Initiative. It is an initiative by the Government of India, the state government, to strengthen the hypertension management component of important program for central government and state government is called NPCD-CS, a national program. The strategy is to improve the screening, also coverage and control. The partners are ICMR, WHO, Ministry of Health, state governments, Vital Strategy and RTCL. They say hypertension is 200 million people in India, 50 million are under treatment, but unfortunately under control was only 20 million, that is 10%. So our aim is to make the 10% to 30% by the year 2022. And of course, World Hypertension Day also says this time, you measure your blood pressure, control it and live longer. So you always have to measure blood pressure for everyone. According to me, what is the strategies to increase awareness of hypertension? I classify roles into P. Remember the word P. P. First P is practitioners. Irrespective of whether physician, pediatrician, obstetrician or surgeon, then people education and empowerment of the people, and especially the community, pregnancy community, and people who are going to pilgrimage. The third P is people education, that is educational institution, private sector, public sector, government, panchayat, municipality, corporation, central government, state government, public media, television, newspaper, radio, physicians, patient-friendly technology, and all the association, Physician Association of Hypertension Societies. First, I'll come to role of practitioner. What a practitioner is expected to do. You will have to check the BP of every patient who comes for any problem, even the little finger injury. When they come, you have to check the blood pressure. Not only that, even for the attender, you will have to make a checking there, and then you must do family counseling. If somebody has got blood pressure, bring the family and counsel, and then do the counseling, lifestyle modification, etc. You have to talk to them. And start exclusive hypertension clinic. India, we don't have an exclusive hypertension clinic. I repeat, in India, there are no exclusive hypertension clinic or hypertensionologist. I think the association like CSI, API, HSI should start focus on, like diabetic clinic. They are focusing only on diabetes. We don't have any clinic like that. We will have to start. And you have to have short video in patient meeting halls, and you should distribute handbills. Every physician should adapt a village and a school and create awareness camps. And telemedicine is very modern days, especially the COVID times, is very useful. Give a talk in radio, TV, write an article, talk about health education periodically. Every doctor should do a health education program. Free health screening camps. Explain about home blood pressure monitoring. I'm glad that SP Gupta was talking about HBM. Promote HPBM among the patients, because blood sugar monitoring is there, home blood sugar monitoring. Unfortunately, home blood pressure monitoring is very, very rare in our country, less than only 5%. We don't have statistics. In Japan, more than 80% of the patients with hypertension have HPBM. Ireland, 100% has. Canada, 100% has. I think we must make everybody to buy home blood pressure monitor, and it will be very useful. If one person has a BP, the whole family can be checked with the same BP monitor. So that is a very good awareness for the hypertension. You must train healthcare workers, especially medical representatives. And this is the home blood monitor beyond home. My concept is home BP means not home BP alone. It is beyond home. Where all you can do, I'll tell you. I donated a BP monitor to one vegetable vendor. You know, she's a hypertensive. She started checking for her whole family every day or every month or whatever necessary. But every day she takes a home BP monitor in the vegetable shop. Whoever buys vegetables, she checks the blood pressure and then tell them you have a blood pressure. And she's very popular now. More people go for buying vegetables because they can check the blood pressure also with her. And the barber shop, you give every BP monitor or one of the barber shop and attach with them, and they will give you guidance. In fact, I presented a paper, Sustainability of Blood Pressure Reductions at Intervals led at barber shop, systemic review and meta-analysis of randomized controlled trials. This abstract was accepted in the European Society and the International Society of Hypertension in the May 2020. Unfortunately, we could not go because of the COVID, but this abstract was accepted in the International Society. So follow that. You give it to some of the nearby barber shop and they will send the patients when there is up. Then you can have shopping mall. Very important because shopping mall, many people, especially husbands, will be waiting outside. So when they are waiting outside, you can check the blood pressure. In the flats, you give it to the flat secretary. Whenever they go for any problem, they check the blood pressure also. And then medical representative, we have trained medical representative. I did a program in the Ganapati festival. 400 representatives were trained and they did a mass screening in the Ganapati festival. So medical representative role will be good because when you tell them, they'll come and to help you. Then railway station, many people wait in the railway station, bus stand. Why don't you give a BP monitor? Take the help of the Rotary, Lions, NGOs. They will help you to donate railway station. And airport, every airport, they are waiting, so you'll have to know. And I'm going to write a paper how the airport and the flight, the BP is varying. The high BP, the high altitude, what is the change in BP? Then banks, every bank, when they were waiting, and then bank employees are very vulnerable, high-risk people, high-risk group. And then I recently promoted BP monitors in police station. Because the police people are also always under tension. So every police station I have in our Tirupur town, about 100 police station, I donated 100 BP monitors. So far, I have donated 10,000 BP monitors to various sectors to promote BP monitoring among the public. So police station, the IG of police is receiving the BP monitor from me. And in the library, public library, when people come, quietly the librarian can be trained and they can always check the blood pressure for the library. So then Hindu, I wrote an article in Hindu, gift a BP monitor to everybody, especially doctors and doctors' family. Whenever you go for a birthday or a wedding anniversary, don't buy any fancy items. Buy a home BP monitor, give to them. If you give to a wedding anniversary couple, the whole family, son-in-law, father-in-law, mother-in-law, father, mother, everybody will be examined. So that will be a very good gift for them. So this is an article I wrote in Hindu. Everybody appreciated and started giving. My friends are giving only home BP monitors for as a gift to others. And this is the place where I have done a lot of screening camps, all over the world, all over the country. And then you create a hypertension clinic in a small village. Then pilgrimage, you give the BP monitor to pilgrimage people, roll up people, participate in health education, promote home BP monitoring, sharing information with relatives and neighbors, and then involve them in all the education matters, and roll up public education institution. Whenever you go for a school or a college, have the application before admission, health education, the curriculum. Adolescents, this is a very, very important aspect because a lot of adolescent hypertension, especially software, you teach them and software people will develop their own apps to develop hypertension, to screen hypertension. So this is school educations. And private sector, I told you banks, and whenever any industry, for example, in our Tirupur, we have got marine industry. All marine industries have a BP monitor and they check the BP for the employee. And then more volunteers to be trained. NGOs like Rotary, Lions can be helpful for the screening camps. And corporate sector, periodical BP checkup. Then public sector, government, especially government is doing wonderful work, especially state government and the central government. They have a lot of schemes for community screening, as mass screening they are doing. And they utilize ASHA workers and ANM workers. These ASHA workers go to individual house and check the blood pressure. And that is the raising the awareness of NCDs. And then ANM supervise. In fact, they take the patient to the community screening and the community health education groups. Then they have general skills, administrative skills. They're developing training for the ASHA workers. They do public media. You take one celebrity like Sachin Tendulkar, ask him to speak about importance of BP, screening the BP, periodical health education in the print media. You write an article, go as a interviewer, expert, talk, motivate. Precision technology, just like weighing machine. My idea is just like weighing machine. When you take the weighing machine, there is a lucky disc comes. Like that, we must have a BP machine kiosk. Yeah, BP kiosk machine all over, everywhere. Whenever somebody wants to go check, they put 1 rupee coin, check the blood pressure. Artificial intelligence, mobile apps that can be used as a technology. Last is other associations. I mean, CSI, HSI, ISH. You must train and start hypertension course, hypertensinologists accept your protocols and make them all understand the importance of starting hypertension and hypertension clinic. All of them have an important role to play. And then drive home message. Please take this message. Buy 3 different cup sizes. Every BP clinic should have a BP cup, 3 different cup sizes. I see most of the physicians also have a BP apparatus, but not with 3 different cup size. Buy 3 different cup size. It may not be more than 200 rupees. Validate the BP monitor. If you cannot validate, buy a new monitor every year. After all, it costs only 2,000 rupees. When you can change it for 6 lakhs worth of car every 3 years, you can change BP monitor 2,000 rupees every year for instead of validation. Promote home BP monitor wherever is possible. Very important. And then balance your life when possible and make time for fun and help others to achieve well-being. And then, as you said, control over diet, takes regular exercise, has time to relax, there's the right in discharge of his duties, observe proper hours of sleep and awakening, and is balanced in action and reactions, emotions and reasons, duties and rewards, can't cause disease, says Bhagavad Gita. Thank you for patient hearing. Thank you very much. I'm ready. I'm happy to answer any questions. Over to Sangara.
Thank you, Dr. Murugadan sir, for your excellent deliberation in the strategies to increase in awareness in India. All your points are well taken. We will have some discussions. Dr. Koshi?
Yeah, I mean, I will start the discussion by asking a question to Dr. Govindan Unni. Dr. Unni, I mean, what would you suggest as the optimal sodium intake, especially in a patient with hypertension? Because various societies have given various values. ACCHA has come with less than 1.5 grams, whereas the other societies say that it is about 2.5, 2.4 grams. And we have already seen about the J curve of the, of the intake with the low sodium. And what will be your suggestion as to, especially in a normal population, as well as in patients with hypertension, what should be the advice that we should keep?
No, I have shown just one slide. For want of time, I couldn't go in depth into it. But I think what I said was that in a hypertensive patient, there are no doubts. It should be the least, that is less than 1.5 gram. But as the blood pressure comes down, the relationship between sodium intake and blood pressure reduction also comes down. So in a normotensive, maybe you can go for a higher level, maybe 2.5 gram or 3 gram. But for a hypertensive, I have no doubt it should be less than 1.5. The J curve is basically one when you aggressively reduce the blood pressure on an acute phase, or in patients who are already salt restricted, like in patients with a renal failure or heart failure. These are the patients who have low BP and have increased mortality. So the J curve is very questionable in the ordinary population. In the ordinary hypertensive, J curve is very questionable. So my message will be, in hypertensive, don't worry, let it be less than 1.5. In a non-hypertensive, be careful. And even in a hypertensive, go slow. Don't try to aggressively reduce the salt intake.
Okay. And one more question. In a hypertensive patient, which diet is better, DASH or Mediterranean? Because Mediterranean, usually there is more of fat, whereas in a DASH, there is not much of fat in this one. Which one is better? Because Americans prefer DASH diet, the Europeans prefer Mediterranean diet. What is your take on message for that particular question? Because of course, in our setting, it is not possible for us to follow either of this diet because of our eating habits. This is an academic question. I just want to know about this.
No, I think there is not much difference between the two. As I said, the basic difference is olive oil, that is unsaturated fat, and red wine. That is the only difference between DASH diet and Mediterranean diet. But if you go by evidence, DASH diets have shown reduction in blood pressure. Good. The DASH trial showed that there was a reduction in blood pressure in people who are on a DASH diet. But for a Mediterranean diet, we have evidence, we have data in the prediment for reduction of cardiovascular events. So if you are a Puritan for evidence-based medicine, probably Mediterranean diet scores over DASH diet because it have shown reduction in events, whereas DASH diet have shown only reduction in blood pressure. But I think it does not make a difference. Both of them are equally good.
Okay.
It suits your taste. Whatever suits your taste is fine.
And one more question, because in Mediterranean diet, I mean, they say that, wine is being served along with the meals. And then actually, I mean, a large quantity of wine will be consumed. It's just like a French paradox, in the Mediterranean diet. Because usually, I mean, they serve, wine along with the meals. So, I mean, the consumption of the wine is also very high because I
I think
don't know exactly.
I think anything in excess is bad. Even Amrita, if you take too much, it is poison. No?
You're
So
right.
in moderation, wine also is good, but in moderation. And maybe if you are taking after food, maybe you will take a lesser quantity rather than before the food. Which most of us Indians take alcohol before food, which is probably bad.
And I just want to, add a few more things to what Dr. Gupta has said about a masked hypertension. And he has very nicely said that it is a specific phenotype of hypertension. I just want to make a few things because of unusual presentation of masked hypertension. Because now it has been noted in the literature that some of the patients may come with minimal cognitive impairment. And we see in the office that their blood pressure may be either normal or little slightly on the higher side. And if you do a neurological examination, including a CT brain, it will be normal. There may not be any lacunar infarct. On the other hand, suppose if we just subject them to a simple MRI, we may see an increased white matter densities, which is usually called as leukorrhiosis. And so the thing is that sometimes if we are not, aware of this one, we may miss some people which may come with in the office with a mild elevation of the blood pressure or a normal blood pressure with slight sort of a loss of memory. The memory is of recent sort of loss of memory. So that is one point. The second point is that I happened to hear a webinar on this masked hypertension and the treatment of hypertension elderly people by the ESC, and they were stressing one point that if there is a loss of nocturnal dipping in ABPM, it is an indirect evidence of renal artery stenosis. I don't know how it is, whether it is that true, but this may be one of the points which I gathered from that particular webinar. And the third point is a very important thing is that in the treatment of hypertension, we are converting a lot of people to a masked hypertensive group. That is a masked uncontrolled hypertension. We call it as a MUT syndrome. It's mainly because of the improper treatment. The only thing is that any patient coming to the clinic, if suppose if we find that there is a large discordance between the BP is normal, but at the same time, that particular hypertensive patient, there is an worsening of this target organ damage. We should subject them to an ABPM and find out whether they have got this MUT syndrome. And one more question to Dr. S.P. Gupta, sir, is that we always say that the subset of this masked hypertension, the nocturnal and also the non-dippers are having a worse prognosis. And also there is lot of LVH and also a lot of target organ damage. What is the reason for this one? Are there any possible explanation for this?
I think there are a lot of evidences there that nocturnal hypertension, if it's sustained during the night, it's the worst parameter as far as hypertension is concerned. That's why I have talked about that ambulatory BP monitoring is more better as compared to home blood pressure monitoring because it identifies the nocturnal blood pressure. Why the nocturnal blood pressure has got more morbidity and mortality, the definite answers are not there. But as you have mentioned, I have mentioned that the stroke, the incidence of stroke is in masked hypertension is as high as sustained hypertension. Similarly, the other neurological like cognitive decline or silent infarcts are also more common in masked hypertension than that is seen. And but why the nocturnal hypertension has more morbidity and mortality, I've got definitely no definite answer. If Dr. Govindan has got any answer to that.
I mean, I agree with what you said. I don't think I don't have anything else to add from whatever you said.
But I think it's time people to go in for more home blood pressure monitoring and do at least once ambulatory BP monitoring to know the exact prevalence of masked hypertension and treat it properly. Because people like the diabetics, when they come to clinic, their blood sugars are almost normal, but when you see their HbA1c, it's high. So similarly, the BP patients also, they take medicines properly when coming to the clinic. So you know that in clinic, the blood pressure is quite normal. But when they go back, they are not taking the medicines properly and their blood pressure is pretty high at out of the office. So that has to be identified, and that can only be identified by regular home blood pressure monitoring or by doing, not very frequently, but doing ABPM.
Dr. Sangram, you have any comments?
Dr. James, anything?
Sir, what is the role of gut antimicrobia? Is it come as a guideline treatment or something for hypertension as well as to reduce the cardiovascular risk in other risk patients? What is the role of probiotics?
So far, it is only in the experimental stage. We still have no real data. I think now people talk about microbiota everywhere, from inflammation to immunity to in all sorts of lifestyle diseases. People talk about gut microbiota. So I think it is in a very early stage. We really cannot say that by altering the gut microbiota, we can either prevent hypertension or treat hypertension. But anyhow, from whatever data we have, it is the good diet like the DASH diet or the Mediterranean diet which promotes normal bacteria in the gut microbiota. So I think there is, even whatever the reason may be, maybe it is another reason to follow a good diet like the DASH diet or Mediterranean diet.
Can I answer also?
Yeah, of course.
Yeah, because the gut microbiota is a molecule of the future. In fact, now there is a tendency for shit transfer, the motion, transplant they do. In one of the cases, they took a motion of a obese person and gave to somebody. And that somebody developed obesity. He has sued in the court because of the mismatched transplantation of the SIT. He became obese. So that means for everything there is a microbiota. Even your intelligence can be changed. If you are a cricketer, you can be a better cricketer if you have that microbiota. So definitely it is a future molecule, and definitely it will have a role. I think everything is on pipeline, and microbiota has definitely a role in everything, not only diabetes, obesity, hypertension, whatever. And regarding the masked hypertension, most of the masked hypertension, if you see in alcoholic patient, diabetic patients, and then as Gupta said, masked hypertension 3 times, if you do home BP monitor day and night, you can, especially a pre-hypertension patient, if you do, definitely you can diagnose masked hypertension. So home BP also is very useful. Apart from ABPM, which is, I call it HBPM, is a poor man's ambulatory blood pressure monitor. 3 times morning and night, NICE the guideline says you can diagnose masked hypertension in a patient with pre-hypertension with home BP monitor.
One other aspect with regard to masked hypertension is that people always talk about masked hypertension, but we have to understand that there is also the masked effect on existing hypertension. Patient may be an existing hypertension, and the BP that you check and in the office may be say 150 over 80. At home, it may be 200 over 90. So there is a masked effect, like a white coat effect on hypertension. It is possible on an existing hypertension also.
That is masked uncontrolled hypertension.
This is a masked uncontrolled hypertension. ACC guidelines clearly says about this. And now presently in COVID times, people with mask, they have hypertension with mask. So anxiety.
And yet another question to Dr. Gupta, sir. I mean, what should be the timing of giving the medicines in the patients with masked hypertension? Should we give it at night or at night? Suppose if there is a...
Ideally, yes. The main dose should be given at night. But if need be, then morning dose may be added. But I think we should start with night dose of the antihypertensive medications.
Well, it can be individualized. It cannot be generalized saying that you should give night, because suppose you are giving the patient a beta blocker and diuretic, you should give only in the morning.
Oh, of course, yes. If you are giving diuretics, definitely in the morning, yes.
So you individualize what comorbidity he has got, what HMOD he has got. According to it, you can change and you can individualize. And the paper says ACE inhibitor. Many trials they gave ACE inhibitor in the night, and they give amlodipine in the morning. If you are giving two drugs, you can always do one in the morning, one in the night. It depends. And then again, ambulatory blood pressure or home BP comes in useful, because when you do the treatment and see how it reacts, so that way we can change. But overall, what Gupta says is okay, but you cannot generalize. Individualize. You must do that. Yes.
No, I just want the patient. No, I just want to agree with Dr. Gupta, because nowadays we are giving only long-acting drugs with good TP ratios. We should not give short-acting drugs, because it is not the practice. Because by giving the short-acting drugs, we are converting many of these hypertensive into masked hypertension. Because especially the general practitioners, they give short-acting drugs in the morning, but they see that the office blood pressure is normal. But actually, they will be having a high blood pressure in the night. So actually, the crunch point is that we should give a long-acting drug with the good TP ratios.
Yeah.
Especially now, every guideline says combination therapy. So as you said, when you give combination therapy, you will have to give that way only.
That was right.
Okay. Koshi, why you are very partial to me? You are asking everybody question. You did not ask me any question. So that means my topic is insignificant.
No.
See, this is what This is what I'm telling you. All over the world and country, certain important public health topics, they don't ask questions. For example, when I talk adult immunization, everybody says adult immunization. They clap, very good talk, but they don't follow.
No, sir.
So what I am asking, you should.
Dr. Muruganathan, you might have seen, I have made a small note of what you have said and congratulating you regarding the 8 P's that you have mentioned in the awareness program, and also the gestures that you have done by donating the BP apparatus to vegetable vendors, into the barber shop, in the shopping malls and all. We should also follow the same footsteps when we are just increasing the awareness in the country. Please don't misunderstand.
Koshi, I want you all of I'm just joking. I want all of you to start exclusively hypertension clinic. Tell me in India who has got exclusive hypertension clinic? Very few. In a diabetic patient, in a diabetic clinic, every small town have got exclusive diabetic. They only treat diabetic. If take, for example, Gupta is a hypertension specialist. Govinduni is a hypertension specialist. But he sees other cases also. He doesn't see only hypertension. Compared to diabetes, the prevalence, incidence, morbidity, all are more in hypertension, 3 times more. But unfortunately, none of us are taking hypertension as a specialty. I think this is the time we must have center of excellence for hypertension, where everything in hypertension complication should come to that center of excellence, and they must start doing. And also, I told you, 3 BP cuffs. How many of us have 3 BP cuffs? How many of them validate? I asked one person, I cannot validate because I have to go to Chennai. I said, why do you want to validate? Buy a new monitor. It costs only 2,000 rupees. He's changing his Maruti car every 3 years once. Can't he change one BP monitor every year with a validated BP monitor? This is what I said. So I think we must promote all these things and lifestyle modification and the screening.
Can I intervene because the time is over? Yes. And the chat box there is one chat has come. Great initiative, Muruganathan sir. So in the chat box it has come. So naturally, not only me, people are also watching you and appreciating your efforts.
Coach, just joking. I'm not.
No, I agree, sir. Now, I think we have to wind up this session and we have to go to the next debate.
Thank you very much, Coach.
I would like to congratulate all the speakers for the excellent presentation and also for their deliberations. And they are very good in sticking on to the time. Thank you so much. And now we will go on to the next session. And it is a debate. It is a debate. And Since there are no chairpersons, can I request all of you to be a chair in this debate also? All the people who are present, Dr. Unni, Dr. Sangram, Dr. James, and Dr. Muruganathan. SP Gupta sir has left, so please be there on the, be the chairperson for this one. I will introduce the topic, and this is on a debate, and this topic is the evidence of universal BP goal of less than 130 by 80 millimeters of mercury is strong. And to support this one, we have Dr. Ashok Goyal, and against talking against this one is Dr. Srikanth Eram. Now, may I invite Dr. Ashok Goyal to talk on this, supporting this particular view. Dr. Ashok Goyal, please.
Hi, good morning to everybody. And I'm sharing my slides. Can you see my slides?
No, not visible, sir.
I can't see my slides.
No, it is not visible.
Yeah, but I have shared it. But can somebody can help me?
Devo.
You are screen sharing.
Sir, open your PowerPoint, sir, in the bottom.
Yeah, I just okay. Okay, now it's okay. Now can you see my slides?
Just a second, sir. It's loading, sir. Just a second, sir.
Now you have to put it in the.
Sir, just go to the first slide, sir, please, because it's a conclusion slide.
Okay. Okay. So can you?
Yeah.
Is it visible now?
No, it is visible, sir. It is visible,
And
sir.
I am audible to everybody.
Yeah.
Okay.
It's audible.
Okay, I should start it. Okay.
Yeah.
Good morning to chairpersons and delegates. I am from Jaipur, Rajasthan, the Pink City. Today I will speak in favor of the evidence for universal blood pressure goal of less than 130 by 80 millimeter mercury in stone. Hypertension is a leading risk factor for CVD and death. The treatment and management of hypertension has been documented to significantly reduce the mortality and morbidity, including incidence of MI, stroke, and heart failure significantly. In 2003, the report of JNC7 defined hypertension as an average BP equal to or more than 140 by 90 millimeter mercury with a treatment goal of less than 140 by 90 millimeter mercury in most patients with hypertension. In 2014, the ACC-AHA in partnership with 9 other professional organizations assembled, charged a 21-member multidisciplinary writing committee to develop a guideline for detection, evaluation, and management of high BP in adults. For the 2014 panel, the BP threshold for initiation of antihypertensive drug therapy was 140 by 90 millimeter of mercury for adults less than 60 years and more than equal to 150 by 90 millimeter mercury for those more than 60 years. Based on new evidences, the 2017 ACC-AHA BP guidelines redefined the hypertension as more than or equal to 130 by 80 millimeter mercury and recommended a BP treatment goal of less than 130 by 80 millimeter of mercury. The key question regarding BP control in hypertension patients remains: what is the target for BP lowering during antihypertensive therapy? The aim of this debate is to identify the strong evidence in support of the universal BP treatment goal of less than 130 by 80 millimeter of mercury. Can I just expand because I can't see the complete slide? Okay, the SPRINT was a randomized controlled trial and examined the effects of intensive antihypertensive treatment goal and comparing the standard antihypertensive treatment goal. The SPRINT screened 14,692 hypertensive patients, a large group, including systolic blood pressure 130 to 180 millimeter mercury, age more than equal to 50 years with CVD or high CVD risk, and excluding patients with history of stroke and diabetes mellitus. The treatment goals were achieved early at 1 year and the mean systolic blood pressure was 136 millimeter mercury and 1 millimeter mercury in standard intensive arms respectively. Trial was stopped early after median follow-up of 3.26 years instead of 5 years, owing to a significant lower rate of primary composite outcome and all-cause mortality in the intensive group as compared to the standard group. Intensive treatment was significantly better than standard treatment irrespective of age, sex, race, initial BP, etc. Outcome rate of primary CVD composite and all-cause mortality were found lower in intensive as compared to standard treatment group by 25% and 27% respectively. In a subgroup, sprint included older adults also with a 34% lower risk of developing the primary composite CVD and outcome, and 33% lower risk of all-cause mortality with intensive versus standard treatment. 2017 ACC/AHA BP guidelines with an independent ERC reviewed the meta-analysis of 15 clinical trials based on a review of approximately 6,000 articles and concluded BP lowering significantly reduced the risk of CV morbidity and mortality regardless of the method, comorbid conditions or mean age of study participants. BP lowering to a target of systolic blood pressure less than 130 millimeter mercury may reduce the risk of several important outcomes of risk of MACE, myocardial infarction, stroke as well as heart failure. Many other independent meta-analyses have also documented the effectiveness of the BP lowering for prevention and CVD events and death. Comparing with standard treatment strongly confirms the benefit of systolic blood pressure treatment target of less than 130 millimeter mercury. Furthermore, this was also true even when the results of sprint were excluded. The meta-analysis did not include sprint and reviewed 19 trials. The more insensitive systolic and diastolic blood pressure lowering compared to intensive treatment significantly reduced MACE by 14%, MI by 13%, stroke by 22%. This systematic review and meta-analysis searched for 123 blood pressure lowering RCTs and concluded a strong support for reduction in vascular risk by lowering systolic BP. Every 10 millimeter of mercury reduction in systolic blood pressure significantly reduced the relative risk of MACE, CAD, stroke, and heart failure, which led to a significant 13% reduction in all-cause mortality. This systematic review and meta-analysis not only provided strong evidence of the BP target was desirable, but in a stratified analysis compared and achieved systolic blood pressure less than 130 millimeter mercury versus more than 130 millimeter mercury. More intense BP lowering significantly reduced relative risk of stroke, coronary events, MACE, as well as CV mortality. In this sequential analysis, 18 RCTs compared and concluded the superiority of more intensive versus a less intense BP lowering strategies for preventing myocardial infarction and stroke. In a review of 17 RCTs in which participants were randomly assigned to a different BP, the demonstrated progressive benefit with lower BP targets from systolic blood pressure less than 160 down to less than 120 millimeter mercury. When the achieved systolic blood pressure less than 120 millimeter mercury was compared with the achieved systolic blood pressure of less than 140, 150 and 160 millimeter mercury, the sensitivity analysis showed a 72%, 97% and 227% increase in stroke respectively. In this large network meta-analysis, including 42 randomized controlled two-arm trials, there was a linear association between mean achieved systolic blood pressure, risk of cardiovascular mortality with the lowest risk at achieved systolic blood pressure of 120 to 124 millimeter of mercury. This recent systemic review and direct meta-analysis of 19 trials in which adults with hypertension were randomly assigned to different BP targets reported a significant reduction in major CVD events and identified a BP target of less than 130 by 80 millimeter mercury as the optimal CVD for the CVD protection. Brass et al. Compared 3 groups of patients and predicted that over a period of 10 years, the total number of CVD events expected to be prevented were 3 million with the 2017 ACC/AHA treatment goal, 2.6 million with 2003 GNC7 panel member report, and 1.6 million with the 2014 recommendations. To summarize, 2015 sprint results provide convincing evidence that treatment to a lower BP goal previously recommended as compared to previously recommended standard goal similarly prevent CVD events. 2017 ACC/AHA BP guidelines with ERC systematically analyzed and meta-analysis performed using best practices and identified 90% reduction in adverse CVD events for systolic blood pressure goal less than 130 millimeter mercury compared with higher systolic blood pressure goal. Many recent large and independent systematic reviews have also reached conclusion entirely consistent with the ERC report. Three showing CVD benefits for systolic blood pressure treatment of less than 130 millimeter mercury compared with the higher targets, and two in the absence of the sprint trial also.
Thank you,
Hence, my
Dr.
thoroughly reviewed and evidence-based answer remains yes. The evidence for the universal blood pressure goal of less than 130 by 80 millimeter mercury is strong. Thank you.
Thank you, Dr. Goel, for showing us the evidence. We'll come back to you after the talk by Dr. Srikant. Now I invite Dr. Srikant to say for the no against this movement.
Yeah, that was a great presentation by Dr. Goel. To some extent, I think he has. Sorry, let me just share my presentation. Are you able to see my presentation?
No.
Just a moment. I am just getting it ready.
Start sharing screen.
I think somebody has to stop sharing screen, I think.
Dr. Goel, have you stopped?
Okay, should I stop?
Yeah. Please stop sharing.
Where is the button? It's okay now?
Just a moment.
It's okay?
Just a moment. I'm trying to share my screen, but.
Can the backup and team support?
Yes. So,
I have my PPT here, but I'm not able to share it.
sir,
Yeah.
just so can you see the green button on the bottom?
Right. Yeah, I saw it.
Just click share, sir.
I'm sharing it.
Okay.
Sorry, but it's giving me some kind of.
No, sir. You already open your presentation, sir.
Yeah, I opened it. Yeah,
Yeah. Just click the share screen.
it's giving me some. I don't know. Okay. Okay. Just a moment.
Yeah. Okay, sir.
Technical team, can you please help him?
Sir, we are contacting sir on the phone, sir. Just a second, sir.
Okay.
I think I have just off the slides. I am not at fault, right?
Yeah, stop sharing, no?
I'll stop sharing, yes. I just removed my slides.
Yeah.
Meanwhile, I give the many thanks to Dr. Dani and our scientific chairman that he has the great courage to conduct this hybrid meeting for the first time and going on very well. And all topics are covered very nicely.
Yeah, a lot of appreciations are coming all
Yeah,
over.
really.
Yeah.
Last time I was attending the EC meeting at Calcutta, and the debate was that it should be continued or not. And 50% of people were telling that no, it's not necessary. This time they stop doing this job. Next time we will do. But I strongly recommended no, at least virtual meeting can be done. because a couple of months back, Dr. N. Khanna conducted one Asiatic meeting virtually, and it was very, very nicely done.
Yeah. Now all ACC, EAC, everything is virtual now.
Virtual now, yeah.
Yeah.
So, I mean, we will just
This is
ask,
a hybrid at least.
no, I think we will ask the center that about this problem that we are having it, because Srikanth is muted also.
Yeah, because without his talk, we cannot go for
We
further.
cannot, that's right,
Yeah,
because
yeah,
he's muted also.
yeah. Let technical people come back to us. That's why they should have a trial run for all the speakers at least.
Mr. Anand Peter, are you there? He's the person in charge of this technical team, Anand Peter.
No, they are speaking on the phone, it seems.
Yes,
That's
sir.
right.
Yes, sir.
Yeah.
Yeah. Okay, sir. Sir, we are for, before it's working, sir. His share screening now only it's not working. So that's why we are discussing with the phone, sir. Just a second, sir.
No problem, no problem.
Till then, we can have a small discussion, opinion of all the
Yeah,
Okay,
chairpersons.
okay.
Dr.
Yeah,
Goyal,
yes,
Dr. Goyal,
Prashant,
there is a question for
Prashant,
you.
okay.
yes.
Dr. Goyal, there
Yeah,
is
yeah.
only one major trial sprint you feel data is robust, sir, for recommending?
No, no, not only the sprint trials. After that, I narrated with 8 more trials, and they also persistently telling that the lower BP, if it is less than 130/80, the definitely the results will be better as far as the outcome is primary outcome or the secondary outcome.
So, I mean, a question to Dr. Goyal. So,
Yes.
I mean, if you just look back till about the sprint trial, we had a blood pressure of a target of 140/90. Only after the sprint trial, this has come down to this one, irrespective of this age, because there is a problem with the sprint trial is that they were just concentrating only the systolic blood pressure. They did not give too much importance to diastolic blood pressure. And there is no sort of a cutoff for the age. Let the person may be 30 years or 80 years, they are advocating a blood pressure of 130/80. It is a little hard to accept because the recent trials, if you take the ISH or the ESC guideline, the latest one, and also this our own guideline.
Yeah, I'm just sharing it.
Okay, please go ahead.
Just a moment. It's almost done. Is it seen? Right, right. Probably if I'm not seen, at least I'll be audible.
Yes, you are
Yeah, you
audible.
are audible, but
Right, right, right. Thank you, thank you.
Just open the.
Open that one.
Sorry, sorry for that. Hello?
Yeah, please go ahead, open.
Are my slides seen?
No,
Yes,
not
please
yet.
open the slides.
Open the, that's right.
This I think it is hypertension CSI meet.
Sir, are they seen now?
Now,
The screen, the computer screen is seen,
No, okay.
but he is not opening the slides. Basically, he should open. Yes, he should open the slide.
Are they seen now?
Sir, no, sir. No, sir.
Just
We are seeing your folder with.
Okay.
Yeah, just double click on that.
double click
No,
on the.
he's freeze. Sir, you're freeze, sir.
I'm freezed.
Yes, yes.
Okay, just a moment. I'll resume share.
Yeah, okay, sir.
Is it seen?
Now it's
Yes, yes,
yes,
sir. We are seeing the presentation. Just click
yeah,
slideshow.
go ahead.
Right,
Yeah,
right.
make
Done,
it
sir.
screen.
that's right. That's right.
Very sorry for that.
So
Hey,
put on your audio, video. Can you?
Sorry, somehow video is not playing. It's okay. I'll go ahead with it with the audio. Hello? Hello?
Yeah?
Yeah. Am I audible?
Yeah, you're audible.
It's okay. Video is not playing somehow. Dr. Goyal's presentation has made my talk a little easier to be true. I would say, and I would believe that the universal goal of less than 138 is a strict no. And I'll just pitch my reasons for that. The main reason is optimal BP targets are not known basically. The most of the population is very heterogeneous, and assigning one BP target for all of them is not advisable. And most of the studies are heterogeneous. The evidence which we get from those studies, it includes variety of patient populations. The methods which are used for BP measurement are different, and all studies use different treatment goals. So to generalize it, one BP goal based on this evidence is never correct. And if you see all the treatment guidelines which have evolved, so the 140 by 90 goal was set in the 80s, and then in 2004, when JNC 7 came in, the goal was 140 by 90 and 130 in diabetics and patients with CKD. This was mainly based on the HEART trial, and then JNC 8 upgraded to 120. I mean, there was a trial called Accord. I mean, we all know Accord in 2010, and JNC 8 it stuck to the guideline of 140 by 90 because Accord data did not support a lower goal. What all changed was the sprint trial in 2015, where they tried 120 versus 140 of a systolic BP goal. And then in 2017, after sprint, there were two meta-analyses which the previous speaker had shown. And after that, once ACC adopted a goal of 130/80, but in 2019 and 20, the NICE guidelines and all did not support this treatment goal. We'll see why and why is that. If you see, this was a trial which was highlighted, and I believe that there were more critics of sprint trial rather than the takers. The BP measurement technique which was used in the sprint trial was automated BP measurement, which was unmonitored. The patient used to be left in the room, and then, which is very impractical. It can never be used in our practice setup. And most of the benefit of the sprint trial was driven by the heart failure reduction rather than the endpoints of cardiovascular mortality. And there was no reduction in stroke in this, which is very peculiar because all the trials before that had shown reduction in mortality. Diabetics were excluded. There were significant side effects. There was a significant patient dropout in this trial. So there's a lot of criticism behind this trial, and using this trial to support any goal, I don't agree with that. And after sprint, as the previous speaker had shown, there were two meta-analyses. These two meta-analyses, the heterogeneity was extremely high. If you look at the meta-analysis, there were mixed strategies were used. The goals, I mean, they were actually not a single goal. They had trials with multiple goals. And the participants with a wide range of BP targets were mixed in those meta-analyses. And then in 2020, there was a Cochrane review where they had selected trials with at least 50 participants, all big trials, which are properly randomized. And you can see there, these were the trials which are included. And this meta-analysis or this review did not show any benefit of a lower goal when compared to a little higher goal. And as you can see, if you take the sprint trial of goal 130/80, if it is automated, that equals to 140/90 by office measurement. So always I believe that a higher goal will equal to your automated goal. The same goal cannot be used for both low risk and high risk patients. I can see there patients with hypertension without any comorbid illnesses, other comorbidities, you cannot use the same goal, because if you see a hypothetical example, it's always better to use attributable absolute risk rather than relative risk when we are making a public health policy decisions. And if the baseline risk is lower, for them achieving a higher goal is not that beneficial in terms of the health policy. So they don't have significant benefit with a very lower goal. But if they are at high risk, they'll have benefit with a lower goal. So having a one goal for everybody is not advisable again. And patients with large artery disease in the cerebral vessels, they tend to have syncope with a lower goal. It's better to have less intense BP goal in them. Patients with heart failure, there is no quality data to suggest that lower goal is beneficial. Same with diabetics. Accord trial, which came in 2010, did not show that a lower goal was beneficial in patients with diabetics and patients with CKD. You can see their ASK trial, sprint CKD group. they were actually they showed significant decrease in proteinuria, but one trial did not show any mortality benefit. The same with the other trials. But in non-proteinuric CKD as a whole, they did not show any benefit. If you look at the elderly, these are the trials. If you see, the sprint elderly actually was the only trial which showed that significant benefit was there with less than 130/80, and all others they try targets of 140, 150, and that's what it is. The other evidence for except sprint trial is very low. And with isolated systolic hypertension, again, one of the concern is with a lower goal is the J curve phenomena setting in, and there is increased mortality after that. And in low risk patients, there are no blood pressure trials at all in low risk patients. And but if you see the subgroup analysis of MRC and HOPE-3 trial, there was no benefit with a lower goal in patients at lower risk. There are significant drawbacks of a lower goal, mainly the cost of medications, the associated side effects. They need more monitoring, and the most important thing is the adherence. There is, if the patients discontinue treatment, the benefit of antihypertensive therapy is gone. So it's always better to achieve a realistic goal rather than a very aggressive goal. And this is a significant issue. If it's a, we all know it follows a J curve, and if you achieve a lower goal, you tend to have adverse outcomes. So you can see that ACCORD as well as the sprint had significant adverse effects or adverse side effects in patients with intense therapy. You look at the latest guidelines, except ACC-AHA and Indians, which I mean the JAPI guidelines, which probably have copied the ACC-AHA, the NICE guidelines, and they have not adopted a goal of 130/80. So I strongly believe I tend to side with the NICE, the UK guidelines in terms of this when compared to the ACC-AHA, who adopted a universal goal of 130/80. The NICE have not mentioned 130/80 anywhere in the document, because you can see there there is no evidence to suggest a lower goal. They don't agree with sprint trial, and I concur totally with them. Say that the first target should always be 140/90. We can selectively decrease it to 130/80, and there are a lot of trials, ongoing trials, and we should wait for further evidence to say that 130/80 is needed for everybody. Thank you.
Thank you, Dr. Srikanth. Any rebuttal from Dr. Ashok Goel?
Yes,
1 minute, just 1 minute. We are already.
Because we have already.
I just put the points. Yes, Dr. Srikanth has narrated in conclusion that the side effects of the intensive therapy are there, but it is not that significant, and that can be treated if the we monitor the patient, and in those patients where there is a side effect, that can be those side effects are quite reversible. One thing. Second, that what I want to ask that is there any advantage of keeping the patient at that higher standard treatment? Because as he says that adhere to the treatment, I agree that in standard treatment the 2 drugs were used, and in intensive treatment approximately 3 drugs were used. But only thing that's why the polypills are now available. And if we give the polypills to the patient, I think they can adhere to that.
Dr. Prashant, I mean, you want to make any comment?
Yes, sir. I agree with Dr. Srikanth that sprint trial cannot be 100% relied. It had its own drawbacks. It was a more important point. It excluded patients of diabetes. It did not take into consideration of diabetic patients. Also, another drawback is that it was not a double-blind trial. It was an open trial, and of course, the side effect point has already been mentioned. So this should be taken into account.
That's right.
Yeah, so I agree totally, because sprint was a trial. I mean, sprint had a lot of critics. Basically, it has a lot of criticism, and the criticism is still ongoing. Actually, many people, mainly the Europeans, because this is a trial which was done totally in North America. And the Europeans never agreed with the sprint trial, or and it was terminated prematurely. Actually, the most of benefit was due to reduction in heart failure, and because the more diuretics were used in those patients. And the later part of evidence is all based on the sprint trial. I mean, the guidelines were all significantly skewed by the sprint trial, the trial which I don't agree with. So I totally agree. We need it has to be. I mean, we need more evidence to say that a lower goal is beneficial.
But despite saying this one, we can say that even now the latest ESC guidelines which has come after that one, and the ISH also which has come recently, have put it as the 130, less than 138 in younger people. Younger people means less than 65 years. So I think we have to accept that one. There must be evidence to see that the patient, as far as possible, depending upon the patient, because we are not bothered about the condition of the patient. We have to take the patient as an individual patient. Think about the comorbidities, think about the status of the one, the chronological age, the biological age, and then the frailty and also the independence, and then decide about the treatment strategy. And I will say that, I mean, from my part, after all, I mean, we should remember always that the management of the patient with hypertension, quote unquote, it is treating the patient and not the numbers. We always consider the patient as an individual patient and then go ahead and treat the patient. And I mean,
Still there are questions, but I think in the interest of the time, we can wind up. Dr.
please.
Poshe?
Yeah, I mean, we had an excellent, I mean, debate on this particular topic because more and more trials will be coming. Until now, we have to go according to the guidelines, the latest guidelines, and we have to follow that one, and we have to treat the patients according to our sort of, I mean, taking each patient as a single one and tailor the treatment accordingly. Thank you so much, both of the participants, Dr. Goyal and Dr. Srikanth and Sangram and Dr. Prashant, Dr. James, and thank you so much for being a part of this particular debate and the whole session. Thank you so much.
Yeah.
Thank you,
Thank you,
Dr.
organizers,
Have a
for
nice
giving
time.
an
Bye bye.
opportunity.
Thank you.
Thank you, one and all. Thank you.
Thank you. Thank you.
Thank you, chairpersons and expert panel speakers and speakers. Now it is time for a break. We'll have a
Dr. Mohan.
Silacar, India's #1 CCB in management of hypertension. Myotan CN. Bisotab.
The telescope guide extension catheter pushes past the ordinary, delivering the performance you want for your complex clinical practice. With a thoughtful, deliberate design, Telescope GEC features a coil-reinforced, hydrophilic-coated distal segment contributing to superior deliverability, and a solid round push wire that maximizes force transmitted along the catheter.
Check.
For
Sir, while I'm
superior
speaking.
pushability. Our soft TrueFlex tip is made of a soft polymer melted and shaped to precise dimensions, responsively deflecting and providing flexibility. Smooth Pass technology includes 3 components that work together to smoothly channel stents, balloons, and other devices. A tapered distal push wire section, transitioning from a solid round proximal push wire for flexibility. A polymer on-ramp that maintains superior deliverability and channels devices. And the entry port, contributing to smooth device entry and delivery. As PCI evolves, we're delivering the GEC performance you want for your complex clinical practice.
Here, that one.
Telescope GEC.
This one.
An extension of you.
Yeah, Anand Peter screen. Okay. 3 dots. That one. Okay. Pin video. No, I got chat and then where is that gallery view? I cannot see. No, in your screen you are checking. No, in your screen, Anand Peter screen, there are 3 dots. No, timer I can see 11 minutes. No. Start means we have to slideshow. Okay.
Very good morning from CSI Ahmedabad studio. We welcome you all. I am Dr. Anil Kumar Kulshrestha and my co-host is Dr. Jiten Anand. Now we'll invite chairpersons and experts.
Now I invite chairpersons, Dr. Praveen Chandra, Dr. Ratnagiri Kumar, Dr. Praveen Verma, and experts, Dr. Girish PV, Devdatta Bhattacharya, and Dr. Asa Mailman.
Request to chairperson to take over, please. Thank you.
Dr. Ravi Kumar here. Hi, how are you?
I am Dr. Praveen here. Can we start the session? Yeah, first let us invite Dr. Shiv K. Nair, who is the head of department of CVTS and the past president of Indian Association of Cardiac Surgeons. He'll be talking on a very important topic, that's ischemic MR, what the surgeons need to know from the cardiologist. Over to you, sir.
A very good morning to the chairpersons, and I would like to thank the Cardiology Society of India and Dr. P.P. Mohanan in particular for inviting me here this morning. I'm indeed honored. The topic given to me is ischemic MR, what the surgeons need to know for the cardiologist. As we all know, that pre-op decision making in this particular subset of patients is very challenging and complex, especially when there is only a moderate ischemic mitral regurgitation. Now we know that IMR is primarily a myocardial disease, or in fact a valvular manifestation of left ventricular disease caused by ischemic or infarcted myocardium. There is an imbalance between the tethering and closing forces, and moderate to severe MR exists in about 12% of cases of CAD. In fact, post-MI, it is estimated that about 20 to 50% of patients have some degree of ischemic mitral regurgitation. Now, as we all know, there are usually two types of jets seen in ischemic MR. One is an eccentric jet, usually caused by tethering of the posterior mitral leaflet, and a central jet, which is usually called by global hypokinesia or sometimes by extensive anterior wall infarction. The asymmetric IMR, which is associated with inferior infarctions, usually is a result of tethering of the P2 and the P3 segments of the posterior mitral leaflet, and we see a wall-hugging eccentric jet directed posteriorly. In symmetric ischemic mitral regurgitation, as I said, due to an old anterior infarct or global LV dysfunction, we find there is an increased sphericity index and a central jet of MR. IMR can also worsen with the onset of atrial fibrillation, secondary to the LA stretch and annular dilatation. So what are the four key concerns for the surgeon treating ischemic mitral regurgitation? First, we have to know whether the patient has organic or primary MR, or is there a mixed etiology has to be ruled out. Does it warrant surgical treatment? Should we repair or replace the valve? Will it worsen in the future if it is not addressed right away? So it's actually comparing apples and oranges when you come to think about the diagnosis of organic or primary MR versus ischemic or secondary MR. And in this recent article published by Robert Bono, he has defined the leaflet motion as we see mostly in IMR, a type 1 as per the Carpentier classification, where the leaflets are normal and the morphology of the leaflets is normal, yet there is secondary MR, or type 3B, where there is restricted leaflet motion. Of course, it is possible that there is a mixed etiology, but more importantly, it is very important to identify an anterior leaflet override due to posterior leaflet restriction, wherein we must define it as pure secondary MR and not one of mixed etiology. As can be seen in this echocardiographic picture, the apposition is below the annular plane, and as you can see, the override of the anterior mitral leaflet due to the restriction in the posterior mitral leaflet mobility, resulting in severe MR. Now, various criteria for ischemic MR and primary MR has been defined, well defined, and of course, transthoracic echocardiogram is the gold standard because of the optimal hemodynamics in the setting of the echocardiographic lab rather than the operating room. And I would not like to go into all the details, but you are all aware that the figures for ischemic MR are virtually half that what is required for MR of organic origin. Now, the integrated approach to assess MR is basically we depend on the cardiologist to be able to define for us what requires repair. And as you can see from this chart, published recently in the American Journal of Medicine, first we need to define the etiology, of course, to make a diagnosis of secondary MR or ischemic MR. Number two, we need to do a quantification by various variables like the EORA, the regurgitant volume, the vena contracta, the regurgitant fraction. And of course, we must take some caveats into consideration while making a diagnosis of ischemic MR. The reason being that oftentimes the color flow Doppler velocity should not in fact be used for MR assessment. As you can see in these echocardiographic pictures, because of an associated aortic stenosis, the velocity was high and there was a deep penetration of the MR jet. However, on PISA calculation, it was only a mild MR. Similarly, if there's a concentric orifice of ischemic MR, the PISA method might also be inaccurate in assessing the severity of mitral regurgitation, secondary mitral regurgitation. There is no standardization of the recommendations between the American Heart Association, the American College of Cardiology guidelines, and the American Association of Thoracic Surgery guidelines. As you can see here, for moderate ischemic mitral regurgitation, it is very clearly mentioned that mitral valve repair can be considered as per the cardiologist guidelines. However, the American Association of Thoracic Surgery says that CABG should undergo a mitral valve repair if there is associated moderate IMR. In terms of severe ischemic mitral regurgitation, both the associations pretty much say that though the American Association says there should be mitral valve replacement as primarily mitral valve replacement unless certain criteria are fulfilled wherein you can do a mitral valve repair. Mitral valve surgery is again advised in severe ischemic mitral regurgitation by the American Cardiologist Associations. Now, what are the potential advantages and disadvantages of coronary bypass grafting alone versus coronary artery bypass grafting with mitral valve repair for moderate ischemic mitral regurgitation? There is basically that in this subgroup, no difference in long-term mortality and stroke in comparison between the two groups, between CABG alone and CABG plus mitral valve repair. However, if you do add a mitral valve repair to moderate ischemic MR, there is a lower post-operative mitral regurgitation grade, greater symptom improvement and functional capacity, and improvement in ventricular remodeling and function. So the decision to address the mitral valve becomes more pertinent, especially in India, where a large number of operations for coronary artery bypass surgery are done by the off-pump method. Now, there is one absolute contraindication for doing a mitral valve repair. And in this situation, where there's an extensive basal scar, mitral valve repair might not be a successful option. In fact, in this subgroup, reverse remodeling itself might not occur. Now, there are many criteria which have been laid down for echocardiographic parameters, which will result in the likelihood of a failed repair, which include the tethering height, the tenting area, the leaflet angles both for the AML and the PML, the systolic sphericity index, and the wall motion score index. So in these situations, it is probably better and safer to go ahead with the mitral valve replacement as said by Michael Acker rather than a mitral valve repair. Now, there are very many treatment options for ischemic mitral regurgitation. Of course, the percutaneous mitral valve repair by the mitra clip, goal-directed medical therapy, either a mitral valve repair, which can be either an annular procedure or combines certain other subvalvular procedures, mitral valve replacement, and of course, complete revascularization of the myocardium. Now, what are the results in these various subgroups? It's very interesting to note that between mitra clip and optimal medical therapy, there is really no great difference except that the rate of reoperation is lesser. CABG associated with mitral valve procedures versus CABG alone, actually the results are pretty much the same. Now, this is a very recent study, not yet published, but accepted for publication in JTCV as our premier journal, and it involves 8,000, nearing 2,900 patients and from 8 RCTs. And mitral valve replacement versus mitral valve repair. Repair shows an better result early mortality is lower. However, replacement results in better long-term results as there is a lesser incidence of reoperation and a lesser incidence of readmission for heart failure. In restrictive annuloplasty, that is addressing only the annular dilatation, it has been found that adding a subvalvular repair, such as encirclement of the papillary muscle base, is resulting in better outcomes as compared to annuloplasty procedures alone. So as I said, it should be emphasized that mitral valve repair may have a better short-term outcome rather than replacement, and adjunctive subvalvular procedures reduces the risk of major post-operative adverse events. This slide is an extremely important slide, but it just reiterates what I said in the previous slide, that mitra clip has this very similar outcome to goal-directed medical therapy. MVR has a higher early mortality but better long-term outcomes, and adjunctive subvalvular procedures give a better outcome than annuloplasty procedures alone. The difficulty, of course, arises in this moderate MR, which is the gray zone, whether you should do a CABG alone or you should do a CABG with a mitral valve procedure, either a repair or a replacement. Now, there are very many methods of assessing reverse remodeling potential, but they are all a little cumbersome. That includes left tissue Doppler studies, SPECT, CMR, etc. And it is very important that if we could assess the good reverse remodeling potential, avoidance of reverse remodeling, it would allow us to go ahead with the CABG alone, especially in India where we do a number of OPCAPs. Of course, longer-term studies, RCTs are needed to validate this concept. But very recently, from our own very center, one of our major cardiac surgery centers in Ahmedabad, the UN Mehta Center, they did a very interesting study where they found a new variable called the RFEF. That was the regurgitation fraction into the ejection fraction. We all know that ejection fraction alone is not a very specific marker for predicting remodeling. So they use this RFEF, which is regurgitation fraction into ejection fraction, and did a regression analysis and found that if it was more than 0.12, there was a good evidence of reverse remodeling. And if it was less than 0.12, the chances that there would be reverse remodeling were high. And they analyzed at an interval of about 18 months the left ventricular end systolic volume index and found that it was better if there was a central jet and a good chance of remodeling, you could do OpCab alone. But if there was an eccentric jet and have a bad chance of the more chance of reverse remodeling with an index of more than 1.2, it was better to proceed with mitral valve repair or replacement. So in conclusion, moderate IMR remains a gray zone for surgical treatment. An accurate cardiology assessment should include potential for reverse remodeling apart from diagnosis and grading of the severity of MR. Our heart team approach, especially in the setting of OpCap, which is an Indian surgeon's forte, can treat IMR effectively in selective cases if we can assess the potential for avoidance of reverse remodeling. Of course, further research is warranted in this direction. I thank you all for your attention.
Thank you, Dr. S.K. Nair, for that wonderful presentation.
Virtual and all that is not the same as real. Good afternoon. The next speaker would be Dr. Tala Menon. He's a heart transplant cardiologist trained in US, Philadelphia. I think he's in HN Reliance Hospital. Over to you, Dr. Tala Menon. Hello. Dr. Tala. Can you hear me, Girish?
Yes, sir.
I think the next speaker is the online.
Yes, sir, doctor.
I think he's
Sir,
setting
doctor.
up.
Is online? Is he going to come?
Yes, sir.
Maybe you can inform.
Sir, Dr. Meera has some issues with his audio, so
All right.
we are getting it ready. So meanwhile, we can take the
third talk.
Can we meanwhile can we take the next speaker, sir? Once.
Yeah, next speaker.
Yes. Thank you.
Okay.
Can we ask the next speaker to come?
Dr. Bashi, sir?
Yeah, we will. We'll ask Dr. Bashi to talk. Bashi is the current president of Indian Association of Cardiothoracic Surgery. I think he does not require any special introduction. Dr. Bashi, sir.
Thank you. Share screen. Okay. Can you hear me and see me? Hello?
Yes, sir. Yes, sir. Yeah.
Very good morning to all the eminent cardiologists in the panel and in the audience. At the outset, I thank the CSI for organizing such a wonderful meeting in these difficult times and giving me an opportunity to give a talk. And thank my good old friend, Dr. Mohan, for inviting me to give a difficult topic in front of all the cardiologists, whether to use a bioprosthetic valve and what is going to be the future. After 40 years of doing cardiac surgery and experience in valve surgery, I still feel the sad part is that we do not have a perfect valve yet. And as we all know, in the last 10 years, a revolution has happened in valve replacement, especially with the tissue valve, with the TAVR taking over the surgical replacement of aortic valve all over the world with the graphs which all of you are familiar. Now, the indication of TAVR is expanding and more young patients are undergoing the procedures. Now, is this trend applicable in India? I'm basically going to discuss whether the same thing will be applicable in our country because of various reasons which I'm going to talk to you in the coming slides. This is a study from Dr. Manjunath's group, which they did and published in 2000 May to find out the different types of valvular disease. Because if we find the most of the diseases occurring in valvular heart disease is mixed lesion with rheumatic heart disease, about 80% according to his study. And isolated valve lesions is only about 36%. Because still rheumatic heart disease is rampant in most of the parts of the hospitals where the government healthcare is available, and majority of the other degenerative valve disease is coming to the private hospital where they can afford percutaneous intervention or tissue valve. Even putting a tissue valve is very hard certain times in patients who cannot afford because the cost of it has gone up. Now there is another slide where you can see majority of the patient falls in the age group less than 60 years, and isolated aortic valve lesions are less in our country. And study deliberates the over limited penetration of TAVR in Indian population. Senile degeneration of bicuspid valve calcification is common. Lower age group patients with isolated aortic valve disease becomes a major hindrance in our setup. Now, this is a very, very important study which was published recently in the Circulation in 2019. They have studied the long-term results, early results of biovalves and prosthetic valves, comparing the morbidity, mortality, long-term results, and incidence of reoperation. In biovalve in young adults, the mortality is low, 3.3. Late mortality is about 3.29. This is a meta-analysis and systematic review with a micro-simulation study. Late mortality is higher than late mortality reported for ROSE procedures, which is also a valve conservation procedure. And it is higher than mechanical aortic valve replacement, especially in the young adults. We also have published, when I was in CMC, we have published mechanical valve replacement in young patients, 120 patients in 1981, showing good long-term results in people less than 30 years of age. Patients less than 40 years with surgery projected to undergo one or more re-intervention during their lifetime. Thromboembolism and bleeding rates are far lower than reported for mechanical AVR, but not zero. The studies from the ESC, European Society, where they have reported the significantly improved survival rate with the bioprosthesis over mechanical prosthesis. So their recommendation is to do mechanical valves up to the age of 65. So if you see the American Association recommendation, they extend it up to 70 years. Above 70 only they are, or about 75 is a clear indication of doing bioprosthetic valves because of the reasons mentioned earlier. Now, when you compare these another articles in Circulation, which was published, which shows that if you look at the bioprosthetic from a single center study, major bleeding points problem in bioprosthetic valve is 2.2 because obviously anticoagulation is less, but reoperation rate if you see is about 13%. Mechanical valve, the bleeding and coagulation coagulation related problems, anticoagulation related problems is about 8.5%, but reoperation is distinctively much less in the long run. And in the mid and long-term survival, no significant difference has been shown. Now, the durability, these are the different types of valve available, Medtronic, Sorin, Edwards, all valves together. If you put the long-term survival, if you see with in patients, which is showing red, less than 50 years, almost 90% of them require reoperation within the 15 years. And patients over 50 to 60 years, the reoperation rate is still less And above 75 years, you find the survival is very good, almost reaching almost 80 to 90% at about 10 years' time. Now, the problems with the redo aortic surgery, if you keep on putting tissue valves in younger patients, they may require 2 or 3 operations in the future. This is reported from one of the well-known cardiac center, one of the largest open heart surgery centers in the world, Leipzig, Germany. They have reported their complications related to reoperation, where they routinely do. Problems, you can see the mortality is almost like 7%, and so many problems related to bleeding, pacemaker implantation. Definitely, the morbidity is much higher in this group. Another problem which is increasing the degenerative problem with the prosthetic valve is one of the reasons is diabetes. Diabetes is associated with increased faster degeneration in bioprosthetic valve, and we have a high incidence of diabetes in our group. So we have a smaller body surface area. Our aortic annulus size is small. If you look at the number of implants done in India in aortic valve, I would say the average is about 21 size only. 23, very rarely I put a 25 valve. That is the experience in majority of the people. Whereas I remember when I was working abroad about 35 years ago, the smallest valve I have implanted is a 25 valve. They put even 27, 29. I used to be amazed by the size of the aortic annulus. So then low coronary takeoff, mean diameter of the iliac artery also is small. All these potentially increasing the risk of coronary occlusion and the peculiar anatomical peculiarity in our patients. Of course, coming to the cost, of course, we all know, I don't have to elaborate on the cost factor, but especially in India, where the economy is not the best and GDP for health insurance, everything is much less, unless there is support from the government and insurance, it will take little more time to pick up because the cost of surgical AVR is definitely less than a TAVR, especially in our country. Now also TAVR also is predominantly done by many of the only couple of companies, and the Indian valve is coming to the market, which I hope which will be much cheaper as more number of cases are being done. Now the challenges in our population is acquiring proficiency. Of course, all of you are very experienced. Majority of you are doing this procedure, but still, I know that there is a learning curve, and the anatomical factors of our patient limit the routine use of TAVR in many of our patients from our experience and also experience from other people. Now the real indication I would say is non-Agenarians, patients with really low ejection fraction with previous coronary artery bypass graft, chest radiation, who are extremely high risk with the perioperative mortality, morbid obesity, and of course valve in valve where patients had a previous valve replacement with associated comorbidities, and younger patients who want to have pregnancy, those in atrial fibrillation requiring anticoagulation therapy or end-stage renal failure, definitely they are very good candidates. Now the future perspective, I feel that development of mechanical valves may come, we are not sure, or an ideal valve may come which is genetically engineered, which will help us, or newer drugs which can take off the complications related to oral anticoagulants, and future mechanical valve design with its advanced mechanism reducing the thromboembolic episodes. Now, it's my small experience over the years with the bioprosthetic valve reoperations. This is the valves which I have expanded. You can see the number. I have got quite a good number of valves sitting in my cupboard. I took yesterday a few photographs. How each valve get degenerated. Some of them, you see, the cusp will be like normal, but it's heavily calcified and stiff. Then there is tear of the cusp. And I find in average implantation of valve, in my experience, because I get the patients from outside also, and then around average life of the valve is about 9 years. There is no difference between the mitral and aortic prosthesis. And you can see majority of the patients come less than 60 years, the number is more than 60 years is slightly less in reoperation. Now to come to the which patients I would put a mechanical or a tissue valve, age less than 60, I would definitely try to put a mechanical valve today because the present day mechanical valves are available with better hemodynamic performance and less thrombogenicity. Patients 60 to 70, definitely it is unclear, but I think in our setup we can put over 60 years tissue valve, less than 60, but life expectancy less than 10 years, I will put a tissue valve, or then hazardous occupation, preoperative lifelong anticoagulation. Definitely, I'll put a bioprosthetic valve. High risk bleeding, contraindication of anticoagulants, end stage renal failure and dialysis. Definitely, I would put a tissue valve. So I think to conclude, an unchanged the need for anticoagulation versus need for reintervention. One has to weigh the balance, which way we are going, what is the status of the patient, what is his compliance, where is he coming from, what is his, of course, when we take a decision in our setup, I think half the time we have to think about the financial background of the patient, the place where he is coming from, where is the anticoagulation test available, where he can reach a hospital nearby. All those things we have to put into consideration other than the theoretical things what we all know by experience from other parts of the world. The subset what we deal with is totally different, and there is still no perfect option. Bioprosthetic valve in the young patient, there are some people who advocate to put bioprosthetic valve in very young patient. I think it's more of a fashion, and they say their results with the mechanical valve replacement is bad. But I must tell from my experience over 40 years, anticoagulation management is done properly. It is a mechanical valve in our setup will have good results. Most important thing I always insist on my colleagues and assistant is before operating on the patient, education of the patient in our setup is very important to get a good results, and keep in contact with the patient, explain to the patient in details. So all these things are done. I think my mechanical valve in patients which is indicated will give good long-term results with less incidence of thromboembolism and bleeding thrombosis. Thank you very much once again for giving me this opportunity. I'm grateful to the association, CSI, and the organizing committee of this wonderful meeting. I could see a lot of familiar of my friends in the panel, and thank you all once again.
Thank you, sir, for that wonderful talk. So we will take the discussion will be at the end. We will take a few questions to you, sir. I have at least one question I will ask you.
So,
Over to the next speaker.
sir, Dr. Taha is ready. Can
Yeah,
we?
yeah, next speaker.
Yes.
Hello, Dr. Verma. This is Dr. Chandra speaking. I am joined already. So,
Hello, can I start?
yes.
Am I
Yes, Dr.
audible?
Miran. Yeah.
Yeah.
All right. Great. I apologize for the minor technical glitches from my part. My name is Dr. Talha Miran. I'm a consultant cardiologist at the Sir H.N. Reliance Foundation Hospital in Mumbai. By training, I am a cardiologist with further fellowship training in advanced heart failure and cardiac transplant that I completed in Pittsburgh. I have been with the Mumbai transplant group for the last 3.5 or 4 years. So the topic assigned to me is post cardiac transplant surveillance. So let's begin. So the goals of what are the goals of surveillance? What are you surveilling for? So you want to look for any evidence of rejection. Remember, you always want to diagnose rejection before there is already manifest severe graft dysfunction. You want to make sure that your patients are safely tolerating the immunosuppressants and you're not doing them more harm than good with the immunosuppressants. You want to make sure that with the immunosuppressants on, the patients are not having any serious infections, and you also want to look and prevent any long-term complications such as CAV, PTLD, and other malignancies, and we'll talk about them in detail one by one. So, first thing that you always want to that's always discussed heavily in a talk like this is post cardiac transplant rejection. Um,
preventing rejection is better than treating it, both from a financial aspect as well, and also from a result and prognostic aspect as well. So prevention is better than cure here. How do you prevent that is making sure you have frequent touch points with the patients. Whenever the patients come in, do a detailed history taking. Make sure you're asking for any minor signs of heart failure, any new onset arrhythmia. So if they're having any palpitations, do a detailed clinical physical examination. Look for S3, S4s. During these physical examinations and frequent touch points, you can also do BNP and other various markers, which we'll talk about in a little bit. We use cardiac imaging. Cardiac MRI is getting more and more useful now, in addition to, of course, the tried and tested echocardiography. Finally, we have endomyocardial biopsy and other new kids on the block, such as gene expression profiling with the AlloMap assay and the cell-free DNA, the AlloSure assay. So quickly, first talking about echocardiography, you do your routine echocardiography, look at your LV and RV systolic function assessment. What I would add here, it's very important to always visually compare your patient's latest echocardiograms with their previous echocardiograms. So their echocardiograms may be normal to you. I mean, their LVEF may be 55-60%, but even a slight decrease in contractility could raise suspicions. So you always want to have a direct visual assessment. There is some data coming out of single center studies telling us about the prognostic utility of global longitudinal strain assessments. I think we are still too early in that field, especially in the I'm talking about the post transplant patients. Still don't know what is a significant change. We still don't know what's an absolute normal value. I myself have started doing them routinely just to get a hang of what's normal, abnormal, and hopefully, I think by the end of next year we should have some good enough data to talk and comment more on that aspect. Another important assessment is the RV global systolic function. So initially, post transplant, the patient's longitudinal systolic function assessment, such as the TAPSE and the RVS prime, both are generally reduced. However, by hemodynamics and by visual assessment, you would see that the overall global function is good. So it's important wherever possible, if you have good imaging windows, to look at the global systolic function, look at the RV fractional area change where possible. Then, as you do on your routine echocardiograms, look at the valves, um, assess for diastolic dysfunction. Remember, advanced grades of diastolic dysfunction, a restrictive sort of physiology, could be an indicator of worsening coronary allograft vasculopathy. In addition to this, special mention about trying to assess the anastomosis points, especially the IVC-RA junction, where there could be some turbulence and gradients. This is quite common in the pediatric transplant recipients, where often we have adult donors, and there could be a significant size match. So it's another important part to always pay attention to. So that's echocardiography. Next, we're going to talk about cardiac MRIs. As everyone knows, cardiac MRIs are now being increasingly used all across the country now. There is excellent data from cardiac MRIs using two important variables. The T2, you are obviously looking at your LVEF and RV systolic function, but in addition to all of this, there are two important additional variables that have been extensively studied. The T2 decay time came into limelight, I think, in the early 2000s, where they showed that this was a single center study at Columbia, and they showed that T2 decay time of 56 milliseconds does correlate with significant biopsy proven rejection. About 4 to 5 years later, this is a 2015 study which showed that T2 decay time combined with the RV end diastolic volume index will increase your sensitivity, specificity, and an excellent negative predictive value, as you can see here, of 98% to diagnose rejection. You take the T2 decay time along with the RV end diastolic volume index, put it into a formula, and if the number that you get there is more than 216, then it should raise your index of suspicion for rejection. Again, these are all sort of good rule out test. It will not tell you what kind of rejection it is. This will all trigger, these are all trigger points for performing an endomyocardial biopsy. So that's about cardiac MRI. Then finally, we come to an endomyocardial biopsy. As we all know, most commonly performed via the internal jugular or the femoral vein route, most commonly performed in the cardiac catheterization lab with fluoro guidance. However, if you have the right instruments, the right proper bioptome, you can actually perform it at the bedside using echo guidance. Uh, I have been able to do at least 4 or 5 of these using echo guidance, but the bioptomes over here that we use, they are not as echogenic. So I've switched back to performing them in the cath lab under fluoro guidance. Endomyocardial biopsy is the gold standard method for diagnosing rejection. It not only tells you that there is a rejection, it also classifies the type of rejection, whether it is acute cell mediated rejection or antibody mediated rejection. So you need to tell your pathology lab to not only look at histopath, but to routinely stain all your slides with immunohistochemistry stains such as C3D, C4D, and CD68. There are additional markers as well, but the ISHLT recommends at least looking for these 3 markers on all your routine surveillance stains. Even if you're not suspecting rejection, the recommendation is to look for to stain your slides for these. These are the latest rejection classification from the ISHLT. As I said, it's the kind of rejections are the 2 big groups: acute cell-mediated rejection on the top and acute antibody-mediated rejection on the top. Generally, we do not treat 1 hour cellular rejection very seriously. We may just maintain their a higher goal of maintenance immunosuppression. But generally, if we see any grade of 2 hour or more rejection, that is a trigger point for treating aggressively, perhaps with IV solumedrol or other agents that are easily available. Antibody mediated rejection is never taken lightly. Any grade of antibody mediated rejection definitely warrants a treatment, in my opinion. Yeah, you know, there's a lot spoken about how endomyocardial biopsies are invasive and they could, lead to risk. They could lead to unnecessary complications. However, if you look at large volume centers, academic centers who are performing these endomyocardial biopsies routinely, all of these complications, as you see here, they're thankfully very rare. So, what are the frequencies at which you do? What are the intervals at which you do the endomyocardial biopsies? It's largely program dependent and program driven. Most of the centers in US perform their first biopsy at 1 week post transplant, then the next biopsy is at 4 weeks, then 3 months, 6 months, then one at 12 months, and then from there it's yearly for until 4 to 5 years post transplant. At at my center here in Mumbai, what I generally do is do my first biopsy at 4 weeks, then one at 3 months, then the next one at the 1 year mark, and then yearly until 5 years. During the last few months, we've obviously wanted to avoid our transplant patients venturing out into and mingling with the common public. So we've been doing only for suspected rejection cases. If there's been new change in clinical symptoms, or if there's been a change in the echocardiogram, only then we are doing these endomyocardial biopsies. So what else? If you want to still surveil for rejection, but don't not put your patients through these invasive tests, which will, especially during these COVID times where they would need to come into the hospital. What are the other modalities? So natriuretic peptides are tried and tested. Just a single value of NT-proBNP or proBNP, there's not great data. There's conflicting data as a marker for rejection, especially in the first few months post-transplant. However, if you look at a trend in the natriuretic peptides, that has more prognostic value than just a single value. As you see here, 10 times increase in NT-proBNP increases your odds ratio to 27. Other non-invasive ways is this AlloMap assay is a gene expression profiling of the peripheral blood cells where you're looking for markers of 20 genes which have been validated previously in kidney transplant patients. These are very commonly used in US. More than 90-95% of the transplant centers in US use this. But the caveat about using AlloMaps is that overall, you should have a very low risk for rejection. The patient should not have had a recent rejection episode, and they should be at least 2 months out of their transplants on low doses of Viceloy or prednisolone. The AlloMap assay do feature on the ISHLT guidelines as a class 2A recommendation, again, to rule out acute cellular rejection. Now, the problem with this is it doesn't tell you, it has not
Dr.
been
Talha,
validated to
Dr. Talha, we cannot see your slide. I think your time is over. So can you just conclude because I don't think I see any slides out here.
Can I just show one more slide here?
I don't think you can because it is already
No, sir, no, sir.
controlled from the.
His slide is on, sir. His slide is
So
on.
I can't see your slides. I don't know
No.
how.
Okay, I probably have just 3 to 4 more slides. Would not take more than 2 minutes if that's okay.
So I think you should go to conclusion slide quickly because it's
Sure.
already late.
Sure. Uh, so that was the AlloMap assay. This is the donor-derived cell-free DNA fraction, which is another non-invasive method of diagnosing rejection. You completely overtake biopsy. But again, if you have any issues with any of these tests, it will always trigger an endomyocardial biopsy because none of them have shown to tell you what kind of rejection this is. The next point, I think we're switching gears to immunosuppression. These are the common agents that are used post-transplant. You want to, in addition to monitoring drug levels, you want to make sure that the kidney functions are intact. Uh, Few things I would like to highlight is the everolimus patients on the mTOR inhibitors, everolimus and sirolimus. You need to make sure that they don't have worsening proteinuria and make sure that they do not have interstitial lung disease, which is a rare complication related to everolimus and sirolimus. So HRCT chest maybe once every 2 years and a yearly 24-hour urine protein. Patients who are on prolonged steroids, you should look for osteoporosis and make sure the calcium and vitamin D levels are good. Cardiac allograft vasculopathy, as we all know, is a dreaded complication of cardiac transplant with a very high incidence of around 50% 4 years post-transplant. This is one of my patients. Baseline angiogram post-transplant around 4 weeks, which looked good, as you can see here. Around 4 years post-transplant, you can see this patient developed significant vasculopathy with diffuse disease in the LAD as well as some lesions in the circ. We did an IVUS, confirmed that this looked like CAV, and we stented the LAD and the circ with actually good results. Eventually, this patient developed in-stent restenosis and now is actually relisted for transplant 15 years out of his original transplant. I'll skip the PTLD part. This is my last slide. Very important complication long term is malignancy surveillance. You need to make sure you do a detailed skin examination and you complete age appropriate cancer screening as mentioned here. This is my last slide. Thank you, Dr. Mohanan and the entire team for giving me this opportunity. Thank you.
Dr. Tala, I think this was a very good overview of transplant, how to follow up these patients, transplanted patients. So we had three good talks in this session. I heard two of them, Dr. Bashi's and yours, and Dr. Verma, who is my co-chair here. He has already been throughout the session. So we can now, I think, initiate. Do we have some time, Dr. Verma?
Yes, sir. I think we have around 8 minutes.
Okay.
8 minutes, so we can have a couple of questions to each panelist. I
Okay.
mean, each speaker.
So I think these are very, very important talks, and one, of course, is the first. Of course, we will go to the ischemic MR, and MR is a real issue which keeps taking our patients to more morbidity and more mortality. And these patients who have ischemic MR, they need treatment. We control them initially by medical therapy, but when they fail, then the options are to be kind of explored. And as we have from this topic, what does a surgeon need from the cardiologist? Because many times it was only the surgeon's purview when these patients came to us with significant mitral regurgitation. And so I would like again to have a one point. What does the surgeon need? So let us ask this question again to our speaker, Dr. Nair, on what he's saying about this, what he needs from us.
Thank you, Dr. Praveen Chandra. I think the most important is to differentiate between moderate MR and severe MR. I think that's the first step, because I think in severe MR, there's no doubt that we need to do something, whether it's a repair or a replacement. So if there is severe MR, the surgeon needs to decide whether he wants to do an MV repair or he wants to do an MV replacement. And as I had mentioned in my slides, MV repair has got better immediate results, lower in-hospital mortality, while mitral valve replacement has, of course, better outcomes in the long term, lesser rates of readmission, and therefore mitral valve replacement may be the better option if you believe that the MR is very severe and there are other signs like the tenting height, the tenting distance, basal aneurysms, etc., where you can choose to go ahead with a mitral valve replacement. The other important point that I had made in my talk was when you do a mitral valve repair procedure, you must attend to the subvalvular apparatus because of the splaying of the papillary muscles. Because whether it's an anterior infarct or it's a lateral or inferior infarct, there may be displacement of the papillary muscles and an increase in the interpapillary distance. So these procedures, which have been around for actually more than 2 decades, of bringing the two papillary muscles closer together by a number of techniques, either suturing them together or encircling them with a Gore-Tex tube. A number of procedures have been tried. I think that has been shown in the very recent meta-analysis published in the Journal of Thoracic and Cardiovascular Surgery, that adding a
Thank you, Dr.
subvalvular
Nair.
procedure
Yeah, yeah.
improves the
So
mitral
we will
repair results.
go to the next. We have very important panelists here. Dr. Girish, do we have any points to make or any question to any of our speakers?
Yeah, sir, I would like to ask, what is your conventional strategy for repair? Is it with artificial chordae and annular ring, or a hybrid of both in practice?
Usually it is only an annuloplasty, and definitely I try to see if the papillary muscles, if you are actually able to see both the papillary muscle bases through the mitral valve repair, you don't really need to do anything. But if you are not able to see both the papillary muscles when you look through the mitral annulus by retracting the leaflets, then I think it's a very good idea to do some kind of a subvalvular procedure to bring the two papillary muscles together. But artificial cords, I think if there are rupture of the chordae, it is better to go ahead with in ischemic mitral regurgitation, I think it's a better option to go ahead with a mitral valve replacement. You need to reduce the ischemic time, you need to get the operation done expeditiously, and you need to eliminate that MR, because if you've got some residual MR left, then you're really back to square one. So I think if there's any doubt about your repair, it is better to go ahead and do a replacement.
Right.
And I think a lot of studies show that.
Okay, Dr. Nair. So basically, that was all about the surgical side. I wanted this answer from you, that what is the help you need. In fact, my surgeon, Dr. Trehan and his team, so they have started referring many patients to us for mitral repair through a mitral clip procedure. And only 2 days back, we did a mitral clip with a XT, which is an extended length clip, which we do in patients with degenerated MR with a longer leaflet length. And it works out quite reasonably well. And the interesting aspect is that mitral clips actually, when we do this procedure, it is a 24 to 36 hours hospital admission only, very, very low morbidity. And in fact, it doesn't harm these patients because we don't use any contrast or any such kind of thing during the procedure. So that is working out quite well in many patients, especially these patients who have CAD and they've come to us with a diffuse disease and severe mitral regurgitation where surgery is not possible. So we are not saying that surgeons
Dr. Nair, I would also like to have your opinion about mitra clip. And the second thing is that in which all patients you will not do a surgery? Like which are subset of patients you say that it is too high risk to undergo a surgery? I like to have your comments, sir, because you have large experience in treating ischemic cardiomyopathy.
I personally am very much in favor of actually offering surgery to most patients who come and who are symptomatic, because I think the natural history is so poor that if, of course, we might, worsen the natural history, if you may put it that way, but they may also get better. So I think viability is a very important aspect. Like they say, you can't flog a dead horse. So if there is viability, I would definitely go ahead and fix it. My real dilemma, which I would really ask the audience and the experts here on the field, on the panel, as well as the chairpersons, is when we operate on ST elevation MI early, and there is LV dysfunction uh, uh, and a STMI, and we wait for maybe the drop to come down, and then we take the patient for surgery. At that time, the MR may be mild to moderate. We do a revascularization. We don't know actually the viability status exactly, what has been the extent of the infarct, how much we have been able to salvage. And few months later, they come back with significant amount of MR and PH. That's where I have a huge dilemma. I think that situation, mitral clip, I think has got a good role to play, because taking them up for a second procedure just for the mitral may be very risky. And as Dr. Praveen Chandra mentioned, that the leaflets definitely get elongated. They do get thickened, though we definitely feel the leaflet morphology is supposedly normal in ischemic mitral regurgitation, but there is an impact of the regurgitation jet on lengthening the leaflets as well as the thickening them. So I think in a situation where a patient has had a CABG a few months or a few years ago, now has a ischemic MR, increased pH, I think a mitral clip is good. But comparing directly, I think at the time of revascularization, I think the surgical procedures have got a better outcome than mitral clip as such.
Right.
So I think even the QAPT realigned studies, etc., I think we need to have an RCT to decide on that issue.
Thank you, sir.
Dr. Nair, I think this is a very important point you raised. Very, very important. That in our series also
Dr.
we have
Dr.
patients
Chandra,
undergoing
Dr. Chandra, can
bypassing.
I interrupt for a second?
Yeah,
Like we have
yeah,
two more, two more speakers, so we need to ask some
yeah,
questions to them. So I'll start
yeah.
with the first question to Dr. Bashi. Sir, we see a lot of younger patients now asking for a bioprosthetic valve. How do you counsel these patients in your practice? I think it will be very interesting to see how you are going to counsel that.
Actually, if younger patients, what age group you are talking about?
Like typically you say 45 years, 48 years coming with a bicuspid aortic valve. They said that they want to have a bioprosthetic valve with the future of TAVI. So they read the internet and they come to you, and then how will you counsel them?
No, I try to convince them that what is the best for them. Okay, these are the pros and cons. I explain everything in detail, and this is the data available. This is my experience. If you still want to do it, particularly about tissue well, I will do it, but you must be prepared for this. But there are some patients. I mean, I had a very senior physician who wanted a Bentall's operation. He was only 53 years old. He runs a very big corporate group. He said, "Sir, you put a tissue valve. I will do a tower 10 years, 12 years later." So people who are very insistent on having a tissue valve, I'll definitely put them, or if they can afford. But otherwise, I make it a point that, especially, for example, a 35-year-old fellow come to put a tissue well, I will not put. I said, it is against my principle and my experience. If you want, you can go somewhere else and get operated. I always stick to my guns about my, take my experience, because I have a large experience of valve from CMC onwards. Thousands of cases we had. I did a big follow-up in Vellore when I was there with the DST project, 2,000 cases. So
Yes, sir. Yes, sir.
I have
Yeah.
very good follow-up with if patients are followed up, educate, that's what I said in my talk. Education of the patient and the family is most important when you do a mechanical valve. Usually what happens, the operation is done, patients are not explained properly, they go somewhere else, there may not be medical facility. So,
Thank you, sir. I think we are running short of time. We'll ask one question to Dr. Meeran. Do you think that cardiac MRI will replace biopsies in the future?
I don't think any of these non-invasive markers are good enough at this point to replace
In future.
Uh, I
Yes
don't
or no?
I don't see that in the near future. No. So the
Okay.
answer is no.
Yeah. Thank you. Dr. Chandra, you can sum up.
Yeah. So I think these are three very very important topics, delivered by the most experienced people, I must say, in the country, Dr. Bashi, Dr. Nair, and Dr. Talha, who gave very clear insights as to what is the role of bioprosthetic valve today, and the second is the mitral use of further treatment cardiologist perspective on the mitral regurgitation, and the third is the of course the follow-up of patients of cardiac transplant. So I think we thank them from all the in behalf of CSI, and hope to see you soon next year. This is such an interesting time that we are all doing a conference on Zoom. Thank you very much.
Thank you. Thank you so much.
Thank you,
Thank you,
sir.
Abhilal. Thank you.
Thank you. Thank you.
Can we have the next talk? Dr. Chandra, can you introduce the speaker? Can we have the next talk, Dr. Bahulayan? Sir,
Yeah.
yeah, thank you. Thank you.
All right.
Can,
Right. Yeah. Good afternoon, and dear chairpersons and friends. Now, I'm going to put up my arguments for percutaneous coronary intervention for left main disease. As we all know that bypass graft surgery has been the standard of care in left main disease. Now, we have four trials comparing PCI with CABG in LM revascularization. Syntax, Precombat, Excel, and Noble. Excel and Noble are recent trials, recruiting more number of patients. And Excel included only intermediate and moderate syntax score patients. Excel has excluded repeat revascularization from the endpoints of that particular study, whereas in all the other studies, the endpoints had been composite of death, MI, stroke, and repeat revascularization. Syntax left main used paclitaxel earlier, the generation of deaths in that particular trial. And the 5-year outcome has shown no difference in overall MACE between PCI and CABG. However, PCI treated patients had lower stroke and higher degree of revascularization, repeat revascularization. When the outcome were analyzed on the basis of a syntax score, you will find that in the low and intermediate syntax score, both PCI and CABG had almost similar event rates at the end of 5 years. Whereas those who are in the high syntax score with a score of more than 33, you will find that the surgery has lesser events. PCI had higher events. So therefore, patients with high syntax score seems to benefit more from surgery compared with those in the lower trials. We have an extended follow-up of this trial on 10 years, which showed that in left main, the mortality was more or less similar in PCI and CABG. In CABG, 26.7% and PCI, 26.1%. So even on a long-term basis, we have data to show that in terms of hard endpoints of mortality, PCI compares very well with surgery. Pre-combat trial is a Korean trial which has used the sirolimus-based drug-eluting stent. And the 5 years data showed that the primary endpoint of MACE and individual endpoints of death, MI, and stroke was not significantly different between PCI and CABG. Well, ischemia-directed revascularization has been higher in the PCI group in this trial also. And the 10-year follow-up, this trial has been able to show the similar, exactly similar results as it was shown up in the 5-year results. Now, Excel trial, the last year published Excel trial, which has used a everolimus-eluting stent as the drug-eluting stent. You will find that there is no significant difference in the primary endpoint of death, stroke, and MI at the end of 5 years between PCI and CABG. PCI had got a 22% and CABG has 19.2%. If you look at the curve, you will find that the earlier part, that means in the 1-year period, the event rate were actually more in the surgical arm, especially during the first 1 month, 30 days. procedure-related mortality, procedure-related myocardial infarction, stroke were significantly higher in that particular period of 30 days after the procedure. Even the bleeding has been found to be more in CABG group. Whereas secondary endpoints like death, stroke, MI, and ischemia-driven revascularization put together and analyzed, at the end of 5 years, you will find that PCA had got higher event rates, 31.3 versus 24.19%, which was significant. This was basically because of increase in the number of non-procedure related myocardial infarction and repeat revascularizations. Now, the Nobel trial, this also was on a similar basis. Everolimus eluting has been used in this particular trial and published 5-year data almost similar to similar time of Excel trial. You look at the data here, this is entirely a little different from the previous data. You will find that at the end of 5 years, the PCI had 28% of event rate versus 19% in the case of CABG. But you look at the first initial period of treatment, 1 year, the PCI and CABG had almost similar. In fact, numerically, it was lower on the PCI group. All-cause mortality, there was no difference between the two arms of treatment at the end of 5 years. The difference was basically in the non-procedural myocardial infarction, repeat revascularization, and in stroke. In stroke, you will find that this is the only study which has shown that increased stroke with PCI. But you look at the 1 year immediately following the recruitment into the trial, you will find that the stroke was higher in the CABG group. Now, recently, an excellent meta-analysis has been published incorporating all the 4 trials I have mentioned and one more trial, Detroit. That is the 5th trial, which is a smaller trial, but nicely done. 1 year data has been there. Around 4,612 patients have been analyzed, and you find that the all-cause death there's no difference between CABG and PCI with a relative risk ratio of 1.03. You'll find that some degree of heterogeneity is because of the some increase in the mortality Nobel and X. Cardiac death, again, there was no significant difference, and there is no heterogeneity even after the inclusion of XL. Stroke, you look at that. Stroke also, there is no difference, but as I mentioned, in the case of stroke, especially following the procedure, during the early period, the stroke was higher in the surgical arm. Myocardial infarction. You know that myocardial infarction inclusion has got a lot of problem with the inclusion criteria of enzymatic estimation as well as clinical estimation for or diagnosis for myocardial infarction. But you will find that there is no significant difference between the two arms, CABG or PCI. In PCI group, you will get non-procedural related myocardial infarctions were higher. In CABG, procedure-related myocardial infarctions were higher. Repeat revascularization consistently shows that there is increase in the case of PCI, as all the studies have shown. So I think at the end of the day, we have this data from large randomized controlled trials. And when a patient comes to us and then the angiogram shows a significant left main disease revascularization, we certainly should discuss his problem, including the angiogram in a heart tube. And what are the data in front of us? Similar long-term all-cause mortality. No significant difference in cardiac death or MI or stroke. Unplanned revascularization certainly were more common with PCI. And CABG had a higher risk of procedural events, whereas PCI had higher risk of late events. And heart team should be able to discuss all these outcome data with the patient and convince before we select what treatment for that particular patient. So
can we conclude the slide, sir?
This is my conclusion slide.
Yeah.
When should PCI be considered in LM disease? LM presenting as acute coronary syndrome, LM with ostial and or sharp disease, LM bifurcations which are not technically prohibitive to do, and LM with 3-vessel disease which has got not more than 3 additional non-complex disease like syntax 1 and 2. And obviously we don't have a randomized data, but I will include these patients also who are not willing for surgery, who have got comorbidities who are surgically very high risk, and patients who are high risk for PCI as well as CABG. Don't leave them. If they are symptomatic, try to offer PCI, even if you are doing only an incomplete revascularization. Thank you very much for your patient listening. Thank you.
Thank you, sir. Next, we will have the surgeon's viewpoint. We invite Dr. O.P. Yadava. He is the editor of Indian Journal of Cardiovascular and Thoracic Surgery. Sir, Dr. Yadava, to you, sir. Your audio is not clear, sir. Audio. Can you unmute yourself, sir?
Okay.
Yeah.
Can you hear me, please?
Yeah, yes, sir.
Okay.
Loud and clear.
May I? Good afternoon to you, ladies and gentlemen, and thanks, Dr. Bahulian. That was a great presentation. I enjoyed it. Permit me to enunciate a few incontrovertible facts about left main. Oh boy, okay. One, the platitudinal, it supplies a huge amount of myocardium, and therefore any mishap is life-threatening. Besides the fact that majority have associated downstream multivessel disease, an atheroma of left main is not simple. It continues into proximal LAD and circumflex, and the circumflex originates at 90-degree are facts for consideration for PCI. As also that almost 2/3 of these plaques are eccentric and heavily calcified. Now, syntax score is important. As granted, more than 33, CABG is a clear winner. But ladies and gentlemen, even with a syntax score of less than 33, it has been shown that revascularization is 5 times higher for PCI as compared to CABG. And it's not just one. Revascularization begets more revascularization. Almost 1/4 of them may have 3 or more revascularization, and they translate into increased mortality. This is the Excel finding. So these revascularization are not benign. And that's why Gregory Stone commented to quote, it's a real difference and shouldn't be minimized. Now, besides anatomy, the clinical factors of comorbidities are important, and that's why syntax score 2 and clinical syntax was introduced, and diabetes surgery is clear winner. But even in LV dysfunction in the IRIS main registry, PCI had 2.5 times more primary outcomes than CABG, and in situations like rheumatoid arthritis, hypothyroidism, PCI doesn't seem to do well. Then look at the expertise. The American statistics, 0.5 left main angioplasty per operator per year. This is last year's statistics, current statistics. More than 50, barely 15% doing one left main angioplasty per year. So you need a maverick cardiologist to do a left main angioplasty. And then heart doesn't beat like this. Heart moves, it squeezes. And whenever that happens, a bifurcation stent undergoes torsion, flexion, stretching, leading to stent fractures, and in a left main, it is a catastrophic event. And none of these are picked on a routine angiography. So when we see those beautiful pictures, they show us nothing. 30 to 60% of them have inappropriate stent deployment. And even these imaging techniques are not foolproof. As you can see, IVUS missed 54% of plaque protrusions. Now, as against all these uncertainties, we have a procedure like CABG, all-cause mortality less than 1%. Look at the long-term results, 20 years freedom from reintervention, 60%. And in a head-to-head comparison, recent May Compare registry at beyond 5 years, don't talk of 3 months and 6 months, the death rate was increased by almost 35%. And even in the Excel trial, the death rates diverge late at 5 years because there are late events occurring 2% per year. It's a recent publication with stents. And that's why none other than Gregory Stone said, we have not made any advances between 1 and 5 years. There are ongoing risks. Now we have advances in off-pump surgery, in MECUS or robotic surgery. Look at these wonderful results in left main. We have bilateral IMA with 20%, 90% and upward patency at 20 years. And radial artery matches IMA. Off-pump, no-touch technique. We'll use CVA as a stick to beat the surgeon with. No-touch technique, CVA rates were 0.3%, and in syntax trial, they were less than what they were in PCI. Even if you look at the Excel and the Noble trial, the severe rates are same. And in fact, the Noble trial, CABG is a clear winner. That's a superiority. And in Excel trial, a non-inferiority for PCI was demonstrated. But then we didn't talk of that Excel is a flawed trial. The primary endpoints were changed. The definition of perioperative MI was changed. See, the MI rates, which were almost 19% with PCI using the second universal definition, once we used the SKY definition, that dropped to 5%. And CABG MI rates, which are 3% according to UDMI, went up to 19%. And when a reanalysis was done of a leaked data set by a neutral person, the BBC, they were more than 80% higher MI with PCI. And this has been validated in a recent publication just 3 days back by Sylvain et al. Now, periprocedural MI, they are not mortality generating. Real MI, which are mortality generating, are follow-up non-procedural MI. And therefore, if you remove periprocedural MI, look at that. CABG is a clear winner for death. That's the Godino study. Even a neutral study by Fremantle, who is a statistician in London, 5 years excellence in tech, trial study, 23% increased death with PCI. Same thing, 20%, 28% increased death with PCI. This is mortality I'm talking of. And that is why, even on a Bayesian analysis, it has been said PCI was associated not only with statistical inferiority, but also with clinical inferiority. And that's why all our surgical associations have withdrawn from the joint guidelines. And there is a chorus for NEGM to retract the article. And then we have issues like, where are these advanced technology available? Costs. Those are very important. So to sum up, ladies and gentlemen, let me quote from the NAGM editor, long-term outcome with cabbage are superior. There's no point mudding waters. For survival and freedom from MI, CABG is the best. Thank you.
Thank you, sir. Dr. Girish, can we start the discussion?
Yes, sir. I think thank you both faculty for the wonderful deliberations on the outcomes and data. I would just like to conclude discuss on this aspect, sir. Can we consider in a since we don't in a case where this disease is restricted to the left main and presently IVS and OCT is not cost prohibitive and available to many centers, can that be a low morbidity option? If not very long term, at least for the low morbidity that it offers for isolated left main disease with reasonable outcome comparison with regard to CABG, which probably would defeat it in the long term, sir. With IVS and OCT guided as a standard of care, now that we are available, can that be a consideration?
Is that a question for me or Dr. Baulian?
Yes, sir. Your opinion and Baulian sir's comments together, sir.
Well, I think yes, debates are always polarized. So it was a provocative that left main for all. So in an isolated, as you say, ostial and shaft, Dr. Baulian showed that. I think I would grant that if the patient is a non-diabetic, probably that may be a very valid option, and it will be foolhardy for any surgeon to debate on that.
Thank you, Dr. Yadav. It was a very excellent, illuminative lecture, and you have defended the bypass graft surgery as the best option in most cases of left main. Now, only my submission is that in diabetes, actually, unlike a triple vessel disease, diabetes may not be a denominator to decide between PC and CABG, as evidenced by a largest registry like a Compare MI study, which has shown that diabetes, you will have a higher repeat revascularization and events in both arms. That is what they have found. But then there was no statistically significant difference between diabetic and versus non-diabetic. So unlike triple vessel diseases, there not be a point. Second thing is that you touched on the experience of the operator for left main. Certainly, I would agree with you that a person who performs left main, he should be able to offer what we call in our language as a CABG-like result, so that you can look forward to a better result. And for that, you have to have skill and experience, and you must be doing good number of cases of left eye. The third thing is that how you do the case with you. You have to understand the anatomy very well. And with the introduction of imaging like intravascular ultrasound and optical coherence tomography, which could be used combined in a given case, so that you will find out, you have said that good percentage of tissue protrusion is missed by IOS. But then when you use an OCT for that purpose, it is reduced and then you can take care of that. So the use of imaging, use of physiology, so that unnecessary complicated side branch stenting can be avoided. You have an FFR or IFR. So combining all these modalities with the techniques of revascularization, in most of the cases of bifurcation, unless it is very complicated, unless it is very, very heavily calcified. Even calcium can be managed with newer and newer introductions of techniques like IVL, atherectomy, orbital atherectomy, all these things. You prepare the lesion and you can place the stent nicely without producing problems, getting adequate minimal stent area and all those things. So a perfect procedure,
Thank
if
you.
you could offer to patients which are selected, I think CHIL could be, PCA could be an alternate option. And I fully agree with you that the data is from all the studies are not leaving us with a clear mind that this is
Yes, sir. Thank you. Thank you, sir.
And
I
we
think,
thank all the chairperson, speakers, and experts
yeah.
to help conducting this session. And now I hand over, I request Dr. Jagopal to take over for a lunch on session. Thank you, sir. Thank you very much.
Thank you, sir.
Thank you.
Thank you, sir. Yeah.
Thank you, Verma.
Thank you, sir.
Thank you, sir.
I agree.
Hi, sir.
Awesome, sir.
Yes, sir. Thank you.
Do we have Dr. Jaikopal? Yeah.
Yes, 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 sir.
Yeah.
Give me 1 minute, sir.
Sure. Okay. We're ready.
Sir, Dr. Rajgopal sir's system is shut down, so he's switching on now.
Okay.
Once he comes, we'll start, sir.
Okay. I'm on then. All right. Is Dr. Rajnish joined in already? Yeah. Okay.
Yeah, hi. Hi, I'm
Hi,
here.
hi, Bhavesh here. How are you, Dr.
Yeah,
Rajnish? How are you?
yeah, Dr. Ramesh. All okay? How are you doing?
Fine, thank you so much. Thank you.
Yeah.
So, we hope we have a nice luncheon symposium. I don't know whether you are
Yeah,
to eat along with, but I am not.
yeah,
So,
yeah.
yeah.
A new normal. The COVID has taught us many things. So this is one.
Yes, yes. Yeah,
Hmm.
quite difficult. See that you are still in the mask. So are you in the OPD or in the cath lab? Where are you?
So I'm in the OPD, but we keep shuttling from OPD to cath lab daily. So
Okay.
I have a patient who's so delaying the patient, because of this. Yeah.
It's difficult.
So this is a luncheon session, right?
Yes. So I hope all the delegates who are watching are going to be eating or whatever.
Yeah.
So is this also being shown in, as this is a hybrid meeting? Some of them might be in a hall listening to us there.
Could be, but I think the attendance in the halls should be very thin. I don't think many people have gone there. They called me also, but traveling
Yeah,
still,
I
I
think.
feel.
So we are connected to sir, sir.
Yeah.
Yeah, good afternoon, everyone. I think we have a luncheon session, and I'd like to introduce our two panelists, uh, Dr. Dinesh Kapoor and Dr. Bhavesh. Welcome to this luncheon session.
Hello.
I think we are little late in terms of the schedule, and there was a small problem here in the studio. I think it's been rectified. So the topic of discussion today will be on the DAPT selection in view of the breeding score. I thought the way we would go ahead with this program is, we all know today in the era of PCI, there's a lot of newer agents which are available. There's no doubt about the efficacy of any of the molecules that we have in the treatment. But I think the major problem, because of the newer molecules, also the breeding tendencies that we really try to encounter. So I think the next 20 or 25 minutes we'll have a discussion with our panelists, Dr. Rajneesh and also Dr. Bhavesh. So I would like to start this program by uh, uh, framing a question to Dr. Rajneesh on the factors which are associated with an increased bleeding risk after PCI.
Yeah. So I think this is a very pertinent issue right now, because we have been doing coronary intervention now for ages, and with the advent of newer antiplatelets, ticagrelor and prasugrel, almost universally post PCI we have switched to a DAPT comprising of either prasugrel or ticagrelor or even clopidogrel, but clopidogrel comes lower down along with aspirin. So now once we talk of these newer high intensity antiplatelet combinations, obviously if there is any substrate for bleeding occurring or existing in a patient, then there are high chances of a bleeding risk if we continue with DAPT for a longer time. So what are the factors? The question thrown to me is, what are the factors? So I think the factors are, if somehow patient requires anticoagulation because of miscellaneous reasons, that could be atrial fibrillation. And we know that we can't take off anticoagulation in the form of warfarin or acetrom from a patient of atrial fibrillation. Now, if a patient of atrial fibrillation requires a PCI, so that means that we probably have to think of triple regime, including acetrom and warfarin. So then obviously the bleeding chances go very, very high. The risk becomes very high. Similarly, if the patient has a prosthetic heart valve requiring the anticoagulation, or there are some coagulopathies, known coagulopathies, and patient has already shown some bleeding tendencies along on antiplatelets. So these, according to me, are the four major points where the bleeding risk would be very high in patients who's undergoing PCI, requiring a dual antiplatelet along with anticoagulation or some of the coagulopathy states which he has inherently.
I think some of the newer data on the elderly population, in particular, there's a population trial which has come out. Most in the Asian population, we have some data also from the Canadian group also suggesting that an agent like ticagrelor in elderly might really contribute to a very high bleeding. So I think apart from there's a renal dysfunction, liver disease, and so on and so forth. We go to the second question now. About the determinants of higher ischemic risk. We talked about the bleeding risk. Likewise, I think there are a subset of patients who are at high ischemic risk following an ACS and immediately after PCI. So, Dr. Bhavesh, what are your thoughts on this? And then you approach this?
Yeah, hi, good afternoon, everybody. And I think the most important thing why we are here and why we need the antiplatelet single or dual or triple is the ischemic risk. And we know that ischemia has a very strong relation with thrombosis and platelet aggregation. And we know that we need antiplatelet agents to suppress this and to give us a better outcome in terms of mortality, morbidity, symptomatology, so on and so forth. So I think all patients who need antiplatelet agents are at ischemic risk. But in this subgroup also, we need to find out patients who are at a higher ischemic risk, so that as Dr. Rajnish has nicely put, that there are some patients who have a high bleeding risk. So when you have a high bleeding risk, are you going to still give them dual antiplatelet therapy or higher potent drugs or lower drugs? How do we decide? So we look at the ischemic risk profile of the patient, and the higher the ischemic risk profile, then we err more towards giving a more potent and longer duration of antiplatelet therapy. So these are classified into two kinds of risk factors. One is the clinical risk factors, and the second would be the angiographic risk factors. So the clinical risk factors, the most important thing is acute coronary syndrome. So we know that unlike chronic stable angina, people with an acute coronary syndrome, either an MI, ST elevation MI or a non-ST elevation MI, these ACS patients are more prone to developing thrombosis, and so they have a high ischemic risk. Patients who have had multiple episodes in the past, like multiple MIs or multiple ACS, patients who have had a stent thrombosis despite being on a good antiplatelet therapy, then these are again very high risk for ischemia. Patients who have a low ejection fraction, because they will not tolerate a next event very well. So people with low ejection fraction are also considered as high ischemic risk patients. And then we have the standard things of renal problems and diabetes. So all diabetic people are also prone to thrombosis, and people with chronic kidney disease again have an accelerated atherosclerosis and increase in this thing. So these are some of the clinical risk factors. And then if you look at the angiographic criteria, then you look at the stent profile. So if you have multiple stents, like 3 or more stents, if you have stents which have been overlapping, because that overlapping segment does have a tendency of a stent thrombosis. Then if you have a bifurcation lesion where we have put 2 stents, then again there is a chances of stent thrombosis and recurrence of stent restenosis is going to be high. If you have a stent size which is less than 2.5 millimeter, that means a small size stents. If you have a very long stent more than 60 millimeters, if you have been treating people with a complex thing like a chronic total occlusions, especially the long segment ones, and if you have done an incomplete revascularization, and if you have left behind some significant stenotic lesion, we don't want them to have a second ischemic episode. So these are some of the high risk conditions, both clinical and angiographic.
Yeah, thank you. I think we'll probably have to make it a little brief for want of time. So I think I would like to address another issue to Dr. Rajneesh, is about the duration. You very well brought out about the various clinical as well as antiplatelet features. But then when you want to decide the duration of therapy and then the bleeding risk, how do you do that? Are there any risk scores that you would think into, Dr. Rajneesh?
Yeah. So sorry, I didn't get it. So you're asking in terms of bleeding risk or duration as such?
Duration of antiplatelets. So
Sorry?
the duration of dual antiplatelet therapy, how long you would continue based
Yeah.
on.
So as per guidelines, now the guidelines are pretty clear in terms of duration of antiplatelets. So it all depends whether we are dealing with a stable heart disease, PCI, or acute coronary syndrome, PCI. In stable heart disease, PCI, it's very clear that dual antiplatelets at least has to be carried on at least for a month or 1 month or preferably 6 months. Then we can withdraw if it's a bare metal stent for a month, if it's a drug eluting stent at least for 6 months. But then if it is an acute coronary syndrome, acute myocardial infarction or unstable angina, we are doing a PCI, we have to carry on with the dual antiplatelet for at least 1 year. 1 year is must, and then we can withdraw one antiplatelet and carry on with the remaining one antiplatelet after 1 year. So this is very clear. Now, the dilemma basically is if we are dealing with a patient who is a very high bleeding risk, like the patient I mentioned on atrial fibrillation, already on anticoagulation, or the prosthetic heart valve patient, then the dilemma is, then what we do, we practice with triple regime. Obviously, the ticagrelor and prasugrel is out in this setting. It has to be aspirin, clopidogrel, and warfarin. Triple regime at least for 1 month. Then we withdraw aspirin when continue on clopidogrel and warfarin after a month. So this is the regime we follow in patients who are very high risk, or rather patients who are already on warfarin compounds.
I think just wanted to add that there are, when you look at the acute setting, there is something called a precise DAPT score, which is sometimes helpful. And long term, if you really want to control, continue this therapy, you can also based on certain objective criteria like the DAPT score. Now, I would like to go to Dr. Bhavesh, and then I think we have been informed by the organizers that we probably have to cut down a little bit the timing. So the choices available for the extension of DAPT therapy. For example, you have the high, the moderate, and the low bleeding risk group. And so, what are the choices that are available to us today in terms of anticoagulant therapy?
So when we say that we are talking of extension of DAPT, that means obviously the standard thing is that we are talking of extension beyond 12 months. And then we have got in the low bleeding risk people, we have two options. The standard option is that we continue with our dual antiplatelet drug, whether it's clopidogrel or prasugrel or ticagrelor, and we go on for 24 or months or 30 months or beyond. And now we have the option of a low dose ticagrelor that with the Pegasus trial we can use instead of 90 milligram BD, we can go with 60 milligram BD. There's a strong data that for ticagrelor. And then of course we could also have an alternative therapy where you have continue the monotherapy with ticagrelor beyond the 3 months or 12 months which you treat with DAPT, and that could also give good results. In patients who are at a high bleeding risk, then they say that we need to continue DAPT only if it's very strongly indicated. Otherwise, just continue aspirin. And if you are at a very, very high bleeding risk, then only clopidogrel should be the monotherapy beyond
I think there is some data on the July complex subset which has been presented, which is
Yes.
published also, where monotherapy,
Yes.
even on complex PCI, would be the way to go about. I think that's taken care of. So I think Dr. Rajnish, what about the clinical characteristic that may benefit from the extended duration of antiplatelet? The kind of patient, of course, this has been addressed earlier. This is a high subset where you have multiple stents, multiple LV dysfunction patients, and chronic kidney disease. So, what are your thoughts on that, on extended DAPT?
I think absolutely. You have already answered many subsets in your question itself. That if we're dealing with a patient with left mean stenting or a complex stenting in proximal LAD, bifurcation stents and long overlapping stents, obviously somewhere we are thinking of continuing DAPT beyond 1 year. We are not comfortable stopping one antiplatelet and just continue on one antiplatelet beyond 1 year also. So duration has to be longer in such patients. Now, there are also patients I would like to add. Obviously, you also mentioned chronic kidney disease. So, chronic kidney disease with more metal in the coronaries, especially the complex stenting, these are the candidates for a longer than 1 year DAPT. Also, I'd like to mention one subset here. Now, patients who land up with the acute coronary syndrome despite DAPT. Obviously, that is the most important subset where we can't think of stopping one antiplatelet. We have to continue on a longer term basis. So we are no cardiologist can be comfortable stopping such patients with and carry with only one antiplatelet.
Are you able to hear me?
Yeah, we can.
Yes, it's a little low, but yes, we can hear you, but not very loud.
No, I can. You are audible. Absolutely audible.
So I think I just wanted to take it further. In fact, there's been some of our colleagues tend to use clopidogrel after 1 month of ticagrelor use in terms of the cost factor which is involved. Do you think the swap therapy, do you really follow it in your practice? Do you think this could be recommended? You have some anecdotal data available. So do you think this is an option after Rajneesh,
Yeah, I think this is worthwhile discussing here, because obviously the cost difference is there, and many patients do come and tell us that, this is costly. Can we replace it? So beyond 1 year, first I think there is no substantial data to continue with ticagrelor or prasugrel. There is one trial Dr. Bhavesh also mentioned, Pegasus, where they decreased the dosage of ticagrelor to 60 milligram twice a day rather than 90 milligram twice a day, and they have shown it to be non-inferior. It's not superior. So I think uh, up till now the substantial data is in favor that after 1 year we can fairly and reasonably convert it into clopidogrel rather than continuing with ticagrelor. But yes, even in my practice I have used this ticagrelor 60 milligram twice a day, and it's non-inferior. So both are same. It's not showing a superiority. So I think from the cost factor point of view, if it is not showing a superiority, we can easily convert it into clopidogrel.
Dr. Pavesh, in fact, what would you do? Let's assume that somebody with a high bleeding risk has come to you with an ACS. What precautions you would take? And my question was slightly different in the sense that after 1 month of ticagrelor use, there are a lot of people, a lot of cardiologists would switch it down, switch and de-escalate to clopidogrel. So this de-escalation strategy, do you think it's worthwhile in the Indian population? What precautions you would do when somebody has come with an ACS and it was a high bleeding risk?
So I think the first thing, when we do the procedure and you want to start a DAPT, you look at the precise DAPT score, and the two most important criteria are significant renal dysfunction, and second is a very advanced age. So if you have a very high precise DAPT score, then you know that you're going to start give DAPT only for 3 months or maybe shorter if the patient has a bleed. But if it has a low precise DAPT score, then you can start with a standard therapy and go on for 12 months. And I prefer ticagrelor over any of the other drugs for the many advantages we have. It's more reliable. There is less of resistance. It's more sensitive and faster onset and faster offset. So I prefer ticagrelor over the other drugs. Yeah.
Are there any specific subset where, yeah, any specific subset where you would de-escalate to clopidogrel?
Yes. So once you have decided and started on a DAPT, and then if the patient has a bleed, then that is the time when we have to start thinking. So if the patient does not have a bleed, then you of course continue your therapy. But if the patient has a bleed, then you could do some of the things. One is you can straight away shorten the DAPT, especially we know that there are many trials now. We have the Onyx one, we have the Smart Choice, we have the short DAPT 2, where we all see that if you have a newer generation stent, which now we are all using, then maybe if you are beyond 1 month, and definitely if you are beyond 3 months, then you can just cut short the DAPT and go ahead with a single monotherapy. And if you are still less than that period of time, then perhaps you could change from your ticagrelor or prasugrel and de-escalate to clopidogrel. I think that would be the point.
Dr. Rajneesh, a problem that we can continue to see these days in the COVID era, some of our patients who have had a PCA, multiple stent on ticagrelor plus aspirin, antiplatelets, they have a COVID and then they need a NOAC or an agent like that. So the data is not very robust in terms of the newer anticoagulants along with the potent antiplatelets. So what are your thoughts there? Would you de-escalate to clopidogrel in that scenario and then add a NOAC? For example, the rivaroxaban is off patent. The coming days you'll see more of the use of 2.5 milligram. But Rajneesh, your thoughts on that?
Absolutely. So I think I'd like to add up few more issues to this. One, I'm just often remembering one thing which I like to discuss here. Any history of CVA or TIA, prasugrel is straight away out. It's a class 3 indication for prasugrel. It's contraindicated. So this is one. And second, as I mentioned prior also, any patient, any subset where the patient is already taking warfarin, be it a prosthetic heart valve or atrial fibrillation, or even if the patient had intermittent atrial fibrillation in the present hospitalization and then had ACS, and we contemplate that patient will require or patient will have to be prescribed on warfarin compounds, obviously then we are thinking of aspirin and clopidogrel rather than ticagrelor or prasugrel in this situation. And second, you mentioned, well mentioned about a COVID thing. So COVID is a post-traumatic stress, and at least in a prescription post-COVID, we require to give NOAC. We require to give NOAC for a very short period of 4 to 8 months at least. In this situation, also, I think it's worthwhile thinking of aspirin and clopidogrel because, as you also mentioned, the data with a higher intensity ticagrelor or prasugrel along with NOAC is quite good. So rather than thinking where we are thinking of NOAC or aspirin for a certain period of time, it's worthwhile to think of clopidogrel and aspirin rather than ticagrelor.
Yeah, I think the other thing which I wanted to mention is about prasugrel. You mentioned about prasugrel. This REACT trial showed that it's equivalent, but then it's always been a worry when you see a patient and then elderly patient and you are not sure of the body weight, so you don't tend to use it. There's some data on the 5 milligram of prasugrel. Dr. Bhavesh, would you like to discuss, because we just have 2 more minutes to go, would you like to cover some area which has been left out?
Yeah.
What are your thoughts? How is your prescription practice in terms of prasugrel?
So I think a few years back, clopidogrel was worked for all situations. Like for any situation of coronary disease, you could use clopidogrel. But now I think ticagrelor is fast coming into the picture, and it can be used in almost all clinical conditions. There are some conditions where you cannot use it. One is when you are thrombalizing a patient with acute myocardial infarction, and of course, for at least 6 hours, ideally 12 hours, you cannot use ticagrelor, but beyond the 12 hours, you can definitely use ticagrelor. You can also now use ticagrelor for patients with chronic stable anxiety if they are at high risk, like if they are diabetic and elderly, then you can use ticagrelor. You can use ticagrelor for all sorts of patients with ACS, with PTCA, or with CABG. And you know that trials like the Twilight and the Ticos, we know that after 3 months of dual antiplatelet therapy, if there is a high bleeding risk, then you could safely stop aspirin and continue ticagrelor monotherapy. At that point, with this particular regimen, you will have less bleeding from the patient's blood. At the same time, there is no increase in the ischemic events.
Yeah, thank you, Dr. Bhavesh. I think we're really running short of time. I'm extremely thankful to Dr. Rajesh and Dr. Bhavesh for this wonderful discussion. And I just wanted to end saying that today we are fortunate to have all the modern and highly potent molecules at our disposal. But at the same time, when you assess a patient, you need to really go into the bleeding risk, which was mentioned earlier, very beautifully brought out, and also look at the scenario where you use an oral anticoagulant and a NOAC, and then based on the clinical scenario, decide on the appropriate therapy. And if you have a high bleeding risk, de-escalate clopidogrel. Otherwise, I think in today's practice, ticagrelor probably takes the front foot. And aspirin is slowly on its way out. You find all the major problems. Thank you all for the wonderful discussion. Thank you very much.
Thank you so much for this wonderful discussion.
Very important to know whether it is dissection, whether it is intramural hematoma, whether it is mycotic aneurysm, diseases causing other diseases like chronic atherosclerotic disease causing thoracic aneurysm, vasculitis and inflammatory diseases, aortoesophageal fistula, coarctation. All these pathologies must be known very well. We also must know the natural history and rupture rate of thoracic aortic aneurysm if it is untreated or if it is treated with medical management. Vis-a-vis also, we should know what will happen if they undergo surgical repair or TEVA. So we must know that 40% of the TAA patients who do not undergo surgical repair, they die of rupture, and the mean survival has been less than 3 years, and 5-year survival for patients with a 6 centimeter aneurysm diameter is 54%.
I request the chairpersons for Sabarmathi Hall to please start the session.
COPD and CKD are again risk factors for rupture. Once you know the basics, then as soon as the patient comes, you have to assess the risk. Pre-op risk assessment for TEVA can be subdivided into 3. Generalized risk stratification, which is done with cardiopulmonary exercise testing. If the patient
Hello, madam. You can start, madam. Madam.
Yeah, the chairpersons are not there.
Just a minute, madam. Um, Madam, we'll start the session with the speaker, and we'll get the chairpersons in on the platform, ma'am.
Right. So, do you want us to start? Can we invite the first speaker? He's there.
Yes, ma'am. Sir.
Am I audible?
Yes, sir. Could you start sharing your screen, please?
Yes, yes. Is it visible?
Yes, sir. Please go ahead.
Okay, thank you. Very good morning to all. So, without wasting any further time, I would start my talk. So, the topic for today allotted to me is the risk of CVD in meat eaters, fish eaters, and vegetarians. Your risk is what you eat. Now, as we all know, nutrition science is a difficult one because there is a huge amount of epidemiologic data which relates to the outcomes of various types of diseases, mortality, standardized mortality rates, and the pattern of diets. But the cause effect relationship is not very clear, and it is difficult to perform a randomized study based on the patterns of diets. And as we all know, vegetarian diets are very popular these days because of presumed beneficial effects on lower mortality rates, as well as lots of previous studies showing that the vegetarians and especially the pure vegetarian diet, they die, the mortality rates are almost half of the overall populations in their specific regions, and they become very popular, almost 20 to 50% lower mortality rate as compared to meat eaters have been demonstrated in various studies. But these are contradicted by many other studies which have shown that there may not be so much reduction in the relative mortalities if you are a pure vegetarian. Now, the healthy volunteer effect is one thing which we must be aware of, that healthy people are more likely to volunteer for such studies than unhealthy people, and other factors like lower smoking rate, healthier lifestyle, and healthier habits in general may contribute to the effects which are shown in such studies. So how do we arrive at a conclusion? So the hierarchy of evidence applies to the science of nutrition as well. And as I said, randomized trials are difficult to perform in this field. So mostly we rely on the outcomes of prospective cohorts on disease outcomes, especially coronary artery diseases. Now, as we all know, diet has an effect on lipids. Definitely, it has been shown that the what food you eat affects your cholesterol levels in the body. But whether this increase or decrease in blood cholesterol translates to actual events in the life, it is still debatable. Similarly, it is applicable to the effects of diet on thrombosis, like effects of omega-3 fatty acids, their anti-thrombogenic and anti-arrhythmic action. It is definitely there, but whether it actually translates in longer life, that is still to be seen. And as I said, individual components of diet have been tested in various trials previously. For example, the Oslo Diet Heart Study or the Los Angeles VA study, Lion Heart Study, all these trials, what they did, they tested the specific components of diet. For example, comparison of saturated fat versus non-saturated fat, or comparison of a specific type of diet pattern compared to another specific type of diet pattern. comparison of fish oil supplementation to not having fish oils in the diet, comparison of with nuts, soys, garlic, etc. And what I mean is that various individual components have been tested and tried. The individual components overlap. A vegetarian guy may or may not take garlic in his diet, or a meat eating guy may be taking a lot of protein sources from vegetarian sources as well, and the lifestyle measures they also different. No randomized study, as I said, is there to compare actually between the vegetarian diet as non-vegetarian diet. So the only way we can rely on is on the prospective studies as well as some meta-analysis which are available to us. As you can see in these slides, these are the few prospective studies, cohort studies which are available with us for the comparison of cardiac outcomes in vegetarian versus non-vegetarian diets. And out of these, the most important and the largest study is the EPIC Oxford study, which I'll be discussing in subsequently. So before that, I would just give a highlight of some meta-analysis which have been done in the past. This Key et al. Meta-analysis, which came in 1999, it compromised detailed findings from a collaborative analysis of 5 prospective studies. And it was shown by Key et al. That vegetarians had a 24% lower risk of ischemic heart diseases, but there was no difference for stroke, cancer, and all causes mortality in vegetarians as compared to meat eaters. Similarly, Huang et al. Performed a comprehensive meta-analysis of cardiovascular disease mortality and cancer incidence in vegetarians. And they also showed that overall cancer incidence and mortality from ISD were significantly lower, but there were no associations with the vegetarian diet with all-cause mortality and mortality from circulatory or cerebrovascular disease. So more or less similar findings were in the AHS2 study. They said that vegetarian diet seems to have a protective effect on CHD and almost 12% reduction in the incident CHD in people who are completely vegetarian. But I'm sorry for the thing. Then came the Oxford EPIC Oxford study. This was a very large study with almost 18 years of follow-up, and they classified the participants in 3 groups: meat eaters, fish eaters, and the vegetarians, and had 18 years of follow-up. This study had a very interesting set of findings. What they found out, as you can see in this forest plot clearly, that the risk of ischemic heart disease was lower in vegetarians and fish eaters as compared to the meat eaters. But the risk of stroke, especially the ischemic stroke, hemorrhagic stroke, and total stroke, if you see, hemorrhagic stroke was higher in vegetarians as compared to fish eaters, and in the meat eaters it was even higher. So what they concluded was that vegetarians had a almost 22% lower risk of coronary heart disease compared to the meat eaters. Fish eaters had a 13% lower risk of coronary heart disease than the meat eaters. Fish eaters had no increased risk of stroke, but pure vegetarians had a 20% increased risk of stroke as compared to the meat eaters. And fish eaters had slightly high plasma concentration of HDL than the meat eaters, while vegetarians had slightly lower concentration. Meat-free diet was also associated with low concentration of LDL or non-HDL cholesterol. Vegetarians were also very less likely to develop type 2 diabetes, and despite having lower blood pressure than meat eaters, they still had a very higher risk of stroke. So these findings were a little bit controversial, because on one side they said the risk of coronary artery disease is less, but the risk of stroke is higher. And when these were adjusted for the self-reported incidence of high blood pressure, cholesterol, diabetes, and body mass index, the effects were attenuated, but still the risk of vegetarians, which was lower as compared to meat eaters, persisted. And such difference, what the investigators explained, could be partly attributed to the lower concentration of LDL cholesterol as compared to the meat eaters. And when we look at the absolute risk difference between meat eaters and vegetarians, as you can see in this slide, that almost 10 events are prevented per 1,000 population in pure vegetarians as compared to meat eaters. Means when you take meat eaters as a reference, over almost 10 events are less in vegetarians and 5 events are less in fish eaters as compared to meat eaters per 1,000 population. But the incidence of stroke is higher, which is in 3 in vegetarians and 2.1 in fish eaters. So, what finally I would like to bring this a study which was published in Lancet, where they calculated the EAT Lancet score. This score was based on a questionnaire. 14 questions were there, and each question was given point 1 or 0 based on the specific points derived from the EPIC Oxford study only. The score varied from 0 to 14, and higher the score, the lesser were the chances of having ischemic heart disease or diabetes, although these scores were not associated with the risk of strokes or total mortality. Now, the important point is, if you have a higher score, means you are more likely to be towards a vegetarian source of diet, and less of your protein and fat is derived from the animal origin. So they concluded that the higher the EAT Lancet score, which is supposed to be a reference diet, more inclined towards the vegetarianism as compared to your nutrients derived from animal sources, lesser are the chances that you will have a ischemic heart disease, although this was not associated with the risk of stroke or total mortality. So, in conclusion, we have a lot of data about vegetarians and ischemic heart disease. We don't have any randomized data as such as of now, but the prospective studies, they definitely indicate that vegetarian diet is associated with lower incidence of coronary artery disease and possibly maybe a higher risk of stroke. Now, this higher risk of stroke is not clearly explained, but in previous some of the studies from China and
Sir,
Japan.
sorry to interrupt. Probably we can take this during the discussion. We have really run out of time.
Thank you.
Thank you, sir. Dr. Thomas, you could start sharing, please.
Next speaker is high intensity.
You are muted, Dr. Thomas.
By Vinod Thomas.
You will have to unmute yourself, Dr. Thomas. Yes.
Okay. Am I audible now?
Yes, sir. Please go ahead.
Okay. Good afternoon, all. I first thank CSI organizers for giving me an opportunity to give this talk. My topic is basically high intensity exercise and cardiac safety. So, high intensity exercise is defined as an exercise that gets your heart rate above 75% of your maximum heart rate on an average for about 10 minutes of duration. So that is the definition of high intensity exercise. That is like an exercise which takes more than 75% of your heart rate for at least 10 minutes. As we all know, the maximum heart rate is basically 220 minus age. For a vigorous intensity physical activity, your target heart rate should be between 77% to 93% of your maximum heart rate. A high intensity training is a great way to improve your fitness, and it can be done as a steady state training or a tempo training or a high intensity interval training. So the heart rate can also be calculated as a heart rate reserve can be calculated. That is maximum heart rate minus your resting heart rate and into zero point 0.7 or 0.85, and this is added to your resting heart rate. And 75 to 85 percentage of your maximum heart rate is the vigorous zone for vigorous intensity physical activity. A moderate exercise intensity is defined as 50 to 70 percentage of your maximum heart rate, while a vigorous intensity exercise is defined as 70 to 85 percentage of your maximum heart rate. So the purpose of this exercise is that it burns more calories, it improves aerobic capacity, it increases the anaerobic threshold, and improves insulin sensitivity. But the cons are it gives a lot of stress on muscles, joints, and nervous system and heart, higher susceptibility to overtraining or burnout, and it can sometimes give an irritable mood also. So a high intensity interval training, you need not do every day per week. It's required to do only 2 to 3 times per week for 20 to 30 minutes per session. And a rest between two sessions is necessary for a good recovery of your muscles and heart. So also the blood pressure also, like when you should not do exercise with a high blood pressure, like whenever your blood pressure is more than 200 or by 115, that's systolic more than 200 and diastolic more than 115, you need to restrict your exercise. Otherwise you can do normal exercise. There is no problem at all. And physical activity and exercise training, we all know that it delays the development of atherosclerosis and reduces incidence of CVD events. And a vigorous exercise is defined in another way as it a work of at least more than 6 minutes. Any work which involves more than 6 minutes is called a vigorous exercise. But still, a workload of less than 6 minutes may produce considerable stress on a cardiovascular system of an unfit or an older individual. So when you look at the young individuals developing cardiac problem like sudden cardiac death during exercise, people above 40 will have more of CAD, but below 30 or below 40, they will have more of a congenital cardiovascular abnormalities, including hypertrophic cardiomyopathy, coronary anomalies, aortic dissection, aortic rupture, Marfan syndrome, mitral valve prolapse, arrhythmogenic RV dysplasia, and the various channelopathies and arrhythmias. But those people above 40, they develop more of CAD as the pathological finding during vigorous exercise and cardiovascular death. And among previously asymptomatic adults, the evidence of acute coronary plaque rupture, plaque erosion, and acute thrombotic occlusion is very common. And the triggering mechanisms are increased wall stress from the increased heart rate and BP, exercise-induced coronary vasospasm in the diseased artery segments, and increased flexing of the atherosclerotic epicardial coronary arteries leading to plaque disruption and thrombotic occlusion. So this is what happens during exercise. During exercise, there is an increased sympathetic activity. There is a sodium-potassium imbalance due to dyselectrolytemia, increased catecholamines. When you stop exercise, you have reduced venous return and reduced cardiac output, and there will be peripheral arterial vasodilatation. This all constitutes to reduce coronary perfusion, increase ischemia, and increase myocardial irritability, and chance of arrhythmias and sudden cardiac death. So SCD during exercise, the incidence is very less. The estimated hourly and annual rates of previously healthy individuals are 1 death per 792,000 hours or 15,260 subjects. But the incidence of acute MI is much more than a sudden cardiac death, that is 6.7 times more than a sudden cardiac death. If you do a regular exercise, that 4 session and more than 5 days of exercise per week, your relative risk of developing an MI during cardiac or during exercise is very less. So if you're a regular exerciser, then your chance of developing a heart attack or any acute MI during exercise is very less. Also, if you look at the benefit of doing exercise, it always outweighs the risk of sudden cardiac death or an acute MI during exercise. We all know that like moderate intensity exercise and mixed with little bit of high intensity exercise gives a lot of protection to the heart, which always outweighs the risk of a cardiac event during exercise. So in young athletes planning for vigorous exercise, American Heart Association recommends a cardiovascular screening, including family history, physical examination, ECG, and echo required before participation in 2 to 4 year intervals. For healthy adults, those who are planning to do vigorous exercise testing before starting a program, uh, most of the times they recommend exercise testing before exercise training in patients who are planning for elderly patients who are planning for exercise program. And all patients with diabetes, they recommend exercise testing before starting a vigorous exercise program. So these are the recommendations. In asymptomatic patients with diabetes, you should do a treadmill test or a stress test before starting a vigorous exercise program. And asymptomatic men more than 45 and women more than 55 age who are planning to start a vigorous exercise should undergo a exercise stress testing before starting a vigorous exercise program. A major limitation of exercise testing is that a positive exercise test indicates a flow limiting lesion, but most of the time the plaque rupture occurs in a non-flow limiting lesion, so that could miss certain patients. Even if you do a treadmill, you can miss certain patients because of the risk of plaque rupture in a non-stenotic atherosclerotic plaque. So it is prudent for exercising adults to know the nature of prodromal cardiac symptoms. So most of the patients who develop cardiac symptoms during exercise, sudden cardiac death and all, they have a little bit of prodromal symptoms. So you have to, when you do vigorous exercises and all, you have to watch for certain symptoms like chest pain or angina, fatigue, indigestion, excessive breathlessness, ear or neck pain, malaise, and dizziness and palpitation. So these are the symptoms you should watch for when you do vigorous exercise so that you can avoid certain complications. And healthy adults without non-cardiac disease should be encouraged to develop gradually progressive exercise programs. So you should start slow and build it slow. And the least fit individuals have the greatest risk of exercise-related events. And patients with known cardiac disease also should be counseled to include at least 5 minutes of warm-up and cool-down in their exercise training. So that is also important. We should give a good warm-up and good cool-down period in patients who are having coronary artery disease or cardiovascular disease if they are doing high-intensity training. So in conclusion, vigorous exercise is definitely safe for heart, provided it is executed scientifically. If you are more than 45, more than 55, and diabetes, pre-testing with treadmill, ECG echo for young athletes also required. Start slow, increase intensity slowly. Warm up 5 minutes, cool down 5 minutes, and restrict high intensity exercise to 2 to 3 times per week. And watch for warning symptoms if you have anything. And definitely, doing a regular exercise always gives benefit much more than the risk associated with the high intensity exercise program. Thank you.
Grisha? Dr. Grisha? Sir? Sir? So please unmute yourself, sir.
Yes, yes, yes. Uh, is my slide visible?
Yes,
Am I
sir.
audible?
Yes, sir. You are audible. Please on slideshow, sir, and put on your video, sir.
Yeah, am I visible?
So start your video, sir. Your video.
Where is it here? Am I visible, please? Am I visible?
Yes, sir. Yes, sir.
Am I audible?
Yes, sir. Yes,
Okay,
sir.
may I start? Okay.
Sure, sir.
Respected chairpersons, panelists, ladies and gentlemen, a very good afternoon to you. At the outset, I thank the organizers and chairpersons for having kindly given me this opportunity to deliver a short talk on an extremely pertinent topic, particularly during this time of pandemic, one that's unfortunately not received its deserved attention, namely environmental pollution and cardiovascular disease. Actually, it's not moving. Not, wait a minute. I'm sorry, it's not. Some problem. Okay. As you're all aware, environmental pollution is the largest cause of premature reversible death and disability. The global burden of diseases in 2015 put an estimate of 9 million deaths due to environmental pollution, 4.2 million deaths due to ambient air pollution, and 2.9 million deaths due to household air pollution. While the State of Global Air 2020 gave a figure of 1.67 million deaths due to pollution in India last year. The Lancet Commission on Pollution and Health fabricated the term pollutome, which means a totality of all forms of pollution that have the potential to harm human health as a subset of exposome. That's a measure of all exposures of an individual in a lifetime and how these relate to health. So, pollutants are both chemicals which potentiate risk factor for cardiometabolic disease as well as non-chemical factors which co-segregate and amplifies association. Such factors include temperature, noise, electromagnetic fields, agricultural methods, climate change and ecosystem changes, which are man-made, occupational, social, and mental factors. Pollution-related mortality far exceeds that due to infections, injuries, and substance abuse. The annual excess mortality due to pollution exceeds that of other disease categories with nearly 8 lakh deaths in excess in the European Union, of which 48% were due to cardiovascular disease, namely ischemic heart disease and stroke. Pollutants may be either primary pollutants, which are emitted directly into the air by combustion of fossil fuels, soot particles, and nitrogen sulfur oxides, originating from motorized road traffic, power generation, industrial sources, and residential heating, as well as secondary pollutants, which are formed in the atmosphere through complex photochemical reactions of various compounds, the primary one being the ozone. The particulate matter can be categorized based on the aerodynamic diameter into those less than 10, known as PM10, which are the thoracic particles, PM2.5 to 10, which are known as coarse particles, PM2.5, the fine particles, the most dangerous ones, and those less than zero point 0.1, which are known as ultrafine particles. And they are quantified by mass per volume, expressed as milligrams per cubic meter. The World Health Organization set air quality guideline levels as daily levels not to exceed 10 milligrams per cubic meter and annual levels not to exceed 20 milligrams per cubic meter, these being the lowest at which the total mortality starts to rise. The figure below gives an idea of the particulate size. The gases, mainly ozone and vapor phase compounds, constitute 90% of the pollutant mass, while natural dust from deserts, volcanic eruptions, and wildfires account for 18% of air pollution related premature mortality. PM 2.5 is a heterogeneous amalgam formed from the combustion or atmospheric reactions, and these remain airborne for days and can get transported hundreds of miles. Coming to household air pollution, the mean indoor 24-hour pollution levels range between 200 to 2000 milligrams per cubic meter, while the peak levels due to low efficiency combustion of biomass fuels exceed 30,000. This is a satellite derived heat map displaying the global PM 2.5 levels. Last year it was 83 micrograms per cubic meter in India. Both coronary artery disease and stroke increase with annual mean PM 2.5 as shown by both the global burden of disease and global exposure mortality models. While solid lines show the range for which epidemiologic data are available, the dashed ones extrapolate to the higher concentrations. Shaded areas show the 95% confidence intervals. The figure shows zones of evidence linking air pollution and CV disease. There are three zones. The first zone, which is just the tip of the iceberg, shows the well-characterized adverse cardiovascular effects which account for all-cause and cardiovascular mortality. Zone 2 includes conditions like hypertension, diabetes, MI, stroke, and heart failure for which there is emerging evidence. Zone 3 includes conditions like thromboembolic disease and cardiac arrhythmias for which there is inadequate evidence and need further research. While some of the conditions have or show a related increase in the relative risk, there are others for which it is yet to be determined. There's an elegant study by the Public Health Foundation of India on the relationship of pollution and hypertension. Hypertension not only occurs in adults but also in children as well as offsprings of pregnant women exposed to air pollution. The relationship of cardiovascular disease associated with long-term exposure to PM 2.5 is shown with various standards and interim targets set by WHO. Exceeding this increases the mortality. Like exceeding IT1 increase the mortality by 15%, IT2 and 3 reduce mortality by 6%. While the levels in US range from 5 to 35 milligrams per cubic meter, in India it exceeds 250 milligrams per cubic meter. Cardiovascular mortality has been shown to increase following both acute and chronic exposures to PM 2.5 as well as ozone. While there's no safe lower exposure threshold for PM 2.5, ozone seems to show a threshold at about 25 parts per billion. The number of deaths in India in 2019 attributable to air pollution was about 16.7 lakhs, to household air pollution 9.8 lakhs, PM 2.5 6 lakhs, and exposure to ozone 1.6 lakhs. There's an increasing trend in all except that due to household air pollution, probably owing to the improved living standards with change in kitchen fuels. The figure shows a cause-specific burden in various disease categories: lower respiratory infection, lung cancer, IHT, stroke, COPD, diabetes, and neonatal diseases. The colored part represents the percentage of deaths attributable to pollution. Come to the mechanism of air pollution and cardiovascular events. Air pollution causes oxidative stress and inflammation, which has its effects on atheroma, endothelium, platelets, and heart rhythm, leading to plaque rupture, vasoconstriction, thrombosis, arrhythmia, culminating myocardial ischemia and infarction, and heart failure, and ultimately death. They operate through primary initiating mechanisms, namely oxidative stress, direct translocation, biologic intermediates, and neural reflexes, and then secondary effector pathways, namely endothelial dysfunction, inflammation and immunity, prothrombotic pathways, autonomic imbalance, CNS effects, and epigenomic changes. This is a figure which shows what I had mentioned earlier. At cellular level, they lead to increase in reactive oxygen and nitrogen species, which cause vasoconstriction, cellular proliferation, inflammation, elaborate cytokines, and thrombosis. A word about air pollution and COVID-19. Exposure to air pollution increases COVID-19 deaths by 15% worldwide, mainly by aggravating comorbidities. Both have additive adverse effects, particularly with respect to CVS, because both migrate from the lungs into blood vessels, cause severe oxidative stress and inflammation. PM 2.5 plays a role in superspreading events by favoring transmission. Now, how do we mitigate and reduce air pollution exposure? There are both societal and governmental interventions like shifting to clean fluids, transportation reforms, reduction in traffic emission, urban landscape reforms, emission trading programs, redirection of science and funding, empowering civil society, and publicity. And personal measures like face masks, reduction of traffic exposures, reduction of pollutants from entering the house, and lifestyle changes. Ambient noise is another omnipresent exposure, with emerging data suggesting a large attributable burden of disability to this factor. In many urban environments, with 20% of population exposed to levels exceeding 65 decibels during the day and 55 decibels during nights in Western countries, with an estimated annual loss of around 1.6 million healthy life years. Mitigation is by reduction of speed and traffic percentage, traffic shift from night to day, use of electric cars, low noise emitting tires, noise barriers, and sound reducing windows. Coming to urban design considerations to reduce exposure to pollution. Built environment features modify adverse cardiovascular effects of pollution through indoor living environment, green spaces, road utilities, and transportation infrastructure. Modification of travel behavior, that is, walking, cycling, use of public transport, reduction in private vehicle use, can mitigate adverse effects of air and noise pollution. Green environments can improve air quality, encourage physical activity, and promote social interactions, ultimately improving cardiovascular health. Indeed, there is evidence to support a protective association of green spaces on pollution-associated cardiovascular disease. The take-home message is that air and noise pollution represent significant cardiovascular risk factors. Mandating their inclusion into various disease guidelines along with recommendations for their mitigation. These involve complex economic and geopolitical considerations associated with short-term challenges due to economic incentives, which are substantially misaligned with health and environmental priorities. Measures such as urban landscape reform, transportation reform, shift to zero emission fuels, and ecologically sound lifestyle changes may help simultaneously alleviate air and noise pollution while accomplishing climate change goals. The cardiovascular community thus has a responsibility to promulgate the impact of not only healthy lifestyle and diet, but also air and noise pollution on cardiovascular death. I thank you for your attention. I concluded my talk.
Chairpersons are there. Uh, where they So, if the chairperson are not there, we could start a discussion on this. We have, I think, 10 minutes of discussion with us. So, my first discussion, I think all the three speakers have done great in portraying, these things are important and we all don't pay so much importance to it. But believe me, the science is deeper than what we realize. So, for Dr. Amit Malviya, tell us more. You were trying to complete something when we went off. Would you like to complete what you were saying?
Yes, what I was trying to tell that time, madam, was the Oxford EPIC study. They surprisingly concluded that the risk of stroke, especially hemorrhagic stroke, is higher in vegetarian. Those who are purely vegetarian, the risk of hemorrhagic stroke is higher. Now, how it happens, it was not very clear. But what they said was the risk of hemorrhagic stroke has been related to lower levels of LDL in some of the studies from China and Japan, where they found that in patients who have lower LDL level, the risk of hemorrhagic stroke is high. And this fact was very pertinent to EPIC Oxford study because the blood pressure levels on an average were lower in vegetarians as compared to pure meat eaters, but still the rates of hemorrhagic strokes were higher. So there was some other factor which was on play, and probably they concluded that the lower levels of LDL, which may relate to the stability of cell membranes in the vascular epithelium, relates to the higher level of hemorrhagic strokes. That was the point I was trying to make that time.
Right. I think the right balance is going to be all these three topics are linked. Your
Am I
diet,
audible?
yes, yes. Your diet is linked to, your basal metabolic rate, your
Hello.
anaerobic threshold. Can you go ahead? Are we all audible? So what I'm trying to say is that you cannot, nothing is in isolation. So the nutrition is linked to your basal rate and environment is acting. So all three of them actually we are trying to work in silos, looking at each separately, but all of them are linked. Your nutrition would matter depending on your intensity of exercise, your anaerobic threshold, your fitness. And the exercise advice we'd give a young cardiac patient would be very different from an older patient, as would be his nutrition device. So while there's a generalization is good, I think it's a time of a lot of personalized medicine, and analyzing each of these in the context of the patient becomes extremely important to get a meaningful change. Dr. Padma, would you like to add anything?
About this meat eaters, fish eaters, and vegetarians. But I think most of the people are probably balanced eaters rather than purely meat eaters, purely fish eaters, or pure there are definitely pure vegetarians are there, but the meat eaters and they also. I think we should have a study based on balanced eating rather than the pure meat eaters and fish eaters.
Right, right. I fully
What
agree.
about egg? Egg and CAD. Eggs.
Pardon?
Mirchi, eggs.
Eggs,
Eating
egg.
egg.
Eggs. Eggs and coronary artery disease. Dr. Amit, can you hear us? Unmute yourself. Dr. Amit, unmute yourself. I think
She
unmute
muted.
yourself. I think this very hard to put a one food as good or bad, and I strongly believe it's your metabolism. So patients who are able to get to good levels of fitness, they are able to utilize their
I
time.
think there is. Hello.
Yeah, Amit, the question for you is eggs. I don't think he's able to. So, Dr. Vinod, are you doing anaerobic threshold testing on your routine PHPs for your patients?
No, we are not routinely doing anaerobic threshold testing for our patients. But like on an maybe it can be done for select patients, but on a regular practice, we are not doing an anaerobic threshold testing.
I mean, why not?
But
Don't you think as CSI
yeah,
can evolve to that? Because a patient who comes for cardiac prevention, if you're not guiding him on to what his anaerobic threshold is, has he improved? How is he modifying his risk factors besides giving him a statin or an aspirin? Don't you think our advice should get more scientific in guiding them how much they have
yeah, of
achieved?
course, we can include that. Like we can also include that. But most of the time, like since we have this watches, like lot of gadgets are available. So most of the time, we can get a rough idea about your aerobic and anaerobic thresholds during
What
exercise itself.
What I'm trying to say is that gadgets and AI is going faster than education
Yeah,
society. And
exactly, exactly.
sensors, we are told by our patients how to read. I mean, we don't know how much of our Apple Pulse we are going to read. But the point is, technology is going to be thrown on us. So it's better that
Yeah.
we understand and develop our own understanding and, statements of use of these gadgets, because out there is a world which is just developing stuff and throwing it out to the public.
Yeah, like the new gadgets will give everything like you need, like even your VO2 max, including your VO2 max, will be shown in the Apple Watches these days. So I think the gadgets will definitely help you to give a rough assessment of your most of the values.
Right. Right. I'm not.
What about patients who want to do intermittent exercise, vigorous exercise for
Yeah,
a
but
few
they can do
seconds,
like
then rest?
at least two sessions in a week is good. Like two sessions of high intensity interval training is definitely found to be useful for cardiovascular as well as your overall physical fitness also improves with this 2 days. That is more roughly around 10 to 20 minutes is what they recommend for a high intensity interval training in such situations.
I think you have to warm up and build stamina. So it's not that suddenly a patient can start doing high intensity. Most of them, they make a mistake of putting on the Apple watches and an app and then exercising. That is, I think, wrong. And common sense of stamina building. And this, I think, goes further down into the children today. So most children are playing games without a stamina or fitness, and you're seeing as much as vasodepressor syncope in women and in young kids who should never be falling ill. So I think the impact on exercise as a society, we need to we need to give an official version, because otherwise it's the lifestyle experts whose voice is dominating over our opinions. And we have to study it in depth to really have a say in it, because going ahead for prevention is extremely important.
Yeah,
Prevention.
that's exactly what I said. Like you have to warm up 5 minutes before exercise. Start slowly. Your exercise program should start slow. Build your exercise program slowly, and maybe over a period of 3 months you can reach your goal. That should be the ideal way to do an exercise program.
People with existing coronary artery disease needs more meticulous advice how to exercise. Uh,
Exactly.
I-
Exactly. They have to start
then
with moderate intensity exercise only. They need not straight away jump into any high intensity exercise training. They can start with moderate intensity exercise training, and once you feel that the person is very comfortable, his heart rate is not shooting up very much, then probably he can like a good treadmill exercise testing, and probably he can incorporate little bit of high intensity if everything is fine.
I think in the absence of science, we are limiting our patients. Our patients can do much more, and a lot of it comes from our ignorance. And they are at the mercy of, personal coaches who are doing that. And doctors are happy if they walk earlier, it's enough. I think as a society, each of us needs to engage personally ourselves with exercise to know how to advise our patients and help them realize their potential, rather than just say, oh, this much is enough. I mean, I can't see my patient of 50 years just doing the walk which even an 85-year-old is doing. And if I don't guide him how to improve his stamina, so the whole question ends up being who will give this advice. As cardiologists, we aren't too big or too important to give this advice. It is not small advice, it is life changing advice. And or within our teams we have proper physios who are able to guide patients through their high intensity. It could not may not be 10 minutes, it could be 3 minutes going to 7, 10. And I think we all have to get a method to doing this because there's a lot of science in this and we need to respect it as much as we respect our interventional procedures.
Amit, there is a question from audience. What about micronutrient and macronutrients in diet? From Ajay Sinha from Patna. Importance of macronutrients and micronutrients.
So I think he's not there, but most of the nutrients come from the soil. So any of our plants which are grown in good soil, we do get all our micronutrients well. What most of us don't end up getting is B12. And if you were to check on your STEMIs, I mean, 95% of them would have a homocysteine and a B12 issue. Either it's the absorption or it is the diet. So in the vegetarian part of it, the B12 contributing to thrombosis is important. And most of us who eat, good amount of soil grown vegetables, our soils are good, our micronutrients are not an issue. A lot of this industry, parallel food supplement industry, is pushing these nutrients, I think, to communities which are more into frozen food and shortcuts or processed foods. I hope we are able to not keep our population away from making that a regular way of living, and most micronutrients are provided for.
Madam, we're sorry, we'll have to go on to the point counterpoint as we are run out of time. Can we start? The thing is that uh, Dr. Jyotsna has not been able to log in. Her Zoom has crashed. So we will start with Dr. Rachel and go on to Dr. Jyotsna. Dr. Rachel, please start sharing your screen, please.
दो बचे हैं
Are we running late?
Am I audio? Can you see my screen?
Please go ahead.
Yeah. I'm extremely happy to start this counterpoint because I was more prepared to have the counterpoint. So I'll be starting halfway through. I'm at the outset. My sincere thanks to the CSI, and I'm extremely happy to share the platform with my teacher Padmaja ma'am and Rupa Selva and all the great faculty from India. And the topic is exercise benefits, whether the benefit differ between the gender or is it the same with the gender. Dr. Jolstein is supposed to have the point that it is equal to both gender, and my counterpoint is benefit of exercise is different with gender. And let me start my share my points. So I'm not different in the point that exercise is useful in all both genders. Gender is mostly it's other gender and sex differs little bit, but in effect both sex and gender we can consider as same. So whether it's a female or a male, we can consider that exercise has got big wins, whether it's a health related or a non-health related, or with the physical or the mental aspects, or for all our well-being, exercise is useful. Whether it's a male or a female, it's useful, no doubt. But I differ in the point that the benefit of exercise is same with female and male. No, it's not, because let me see, gender matters a lot in exercise benefits. Because you can see those pictures which I have shared. One is Arnold Schwarzenegger and other is our Aishwarya Roy. And I can say that females exercise for becoming Aishwarya Roy, and the males exercise to become the other bodybuilder. So our concept or our idea or why we exercise differs between these male and female. I think you all will agree to that. Male, men and women report different exercise habits and reasons for exercise. Women reported exercising for weight loss and toning more than men, whereas men reported exercising for enjoyment more than women. That's what studies and observations showed. So why it is different? We don't have to look much. And even Darwin has suggested that men has to be their exercise fitness should be more than women because that is what nature shows. And why when we nurture the two sexes, then also it is totally different. So the psychosocial development differs, and by nature itself, we are different. Men and female are different in their physical aspects, and so they differ in their attitudes and the motivation for exercise. So at the same time, you have to understand that the requirements also differ. Females' requirements for exercise differ from to that of males. Even though females are exercising less than their male counterparts, it does not automatically follow that they are less healthy because their requirements differ. We don't have to exercise as I have hearing the Vinod's high intensity exercise. It is proved beyond doubt that female doesn't need that much vigorous exercise as gents needed. So it's proved by studies that males gain exercise benefits from vigorous physical activity that at more than 6 minutes, but the same benefit can be achieved by females from low or even up to moderate intensity exercises. So the requirements differ between the two genders. So it's proved that those of high intensity exercise need not be needed for a routine health benefits for a female compared to a male, leave alone the sports people. And so for men, exercise itself is the best predictor and quality of life. Higher levels of exercise in men associated with a higher quality of life, irrespective of what reasons they exercise. When they exercise at higher level, their quality of life is definitely differs between for men. But in women, exercising are of two intention. One is for exercising to lose weight and for fitness. So for heavy fitness are associated with lower quality of life, while exercising to improve mood or health are associated with a higher quality of life. So when female exercise to lose weight and for the fitness like body fitness, their quality of life differs. But they exercise for mood or health, their high quality. We ourselves know that when we exercise for appearance, it is associated with higher disordered eating. We have to have so much intense dietary restrictions, lower body esteem. There are higher body dissatisfaction. So when females exercise for the purpose of appearance, majority of females exercise for that purpose, and that is associated with higher their quality of life doesn't much differ much as far as those females are concerned. So we all know the female athlete triad. That is, it's a triad of interrelation of menstrual dysfunction, low energy availability, and decreased bone mineral density when female are exposed to high heavy exercise. Especially this happens in sports, but those females who are not accustomed to exercise, when they exercise rigorously to reduce weight, then they found that there is a definite menstrual dysfunction when occurs when their energy availability is low and their bone mineral density differs. It definitely comes down. Like exercise is supposed to increase the bone mineral density, but when we exercise unnaturally, but when we heavily exercising, definitely has proved that it is not good for female health. So there is a gender difference in health benefits also. For mental well-being, men gain more benefit from vigorous physical activity. The mental health benefits can be achieved by women with the same mental health benefit can be achieved by women with moderate exercise, which seems to be their preferred level. It's proved that osteoporosis women, there is a reduction in the bone mineral density as the circulating estrogen level decrease as menopause, and it is found that regular aerobic exercise is the most evidence based. So females definitely has an edge over male when it comes to the osteoporosis. Definitely female should exercise for the benefit of preventing osteoporosis. Why this the gender specific features of exercise physiology we can have the widely put it in two headings. One is the difference in the sex hormone, and one is the sex hormone exposure. Every cell has a sex that potentially influences the function, the fatigability in men and women definitely. So XX and XY definitely it is there in each cell. So that differs in the attitude and the effects of exercise, and the XX hormone exposure over years, that is definitely more in a premenopausal women compared to a men. Why the gender difference? And all the studies have shown that men and women differ in their body composition, their cardiovascular differences and maximal oxygen uptake, muscle fiber type composition, anaerobic and aerobic exercise capacity, and fuel resources during exercise. Let me come to the body composition. You know, it's an android composition versus a gynoid composition, because men have more visceral fat, but female have more fat in the gluteal region. So that distribution itself is totally different. And when we exercise, we know that less muscle hypertrophy occurs in women compared to men. That is physiology. That is the by nature itself. How much exercise women would leave alone certain bodybuilder women. Other than that, routinely when the same for the same purpose of exercise, men attain more muscle hypertrophy and strength compared to women. With physical maturity, male muscles comprise larger muscle fibers than females, and when they exercise, their upper body strength definitely increases compared to their lower body in men. So cardiovascular difference also occurs. Main cardiovascular physiology is biologically capable of biologically capable of placed under cardiovascular stress, males respond by increasing their vascular resistance and consequently their blood pressure, whereas females increase when for cardiovascular stress, their compensation is mainly by the high heart rate, and that itself can cause fainting when they exercise too much. But that doesn't happen in men. That is why females more faint more during exercise, because their compensatory mechanism to adapt to the high exercise is mostly by increasing the heart rate. So it's not, we don't have any doubt that great left ventricular mass in men
Madam,
and women.
we have overshot your time, madam.
I'm coming down. The muscle fiber composition also differs in men and women, and the source of energy differs because in females it is lipid than carbohydrate, but females have men use more of carbohydrates because there is higher glycolytic capacity due to the increased type 2 fibers. So I am concluding that one size doesn't fit all. There are clear limitation to one size fits all approach for recommending exercise, and I strongly recommend that the current general physical activity recommendations needs to be reviewed for male and female separately. Thank you so much for your patience.
Dr. Jyotsna is there?
Yes, madam. Dr. Jyotsna, ma'am. Can you unmute yourself?
Yeah.
Can you start your camera, please?
Yeah. Good morning, Dr. Rupa. Good afternoon.
And could you start sharing your presentation, ma'am?
Yeah. Are you able to see my slides?
No, madam. Can you start sharing?
You're able to see the slide?
We are able to see the slide layout. We do not have your slides.
Yeah. Now you are able to see it?
No, madam. You have not shared yet.
Not yet. Okay. 1 minute. Are you able to see it now?
No, madam, not yet. Madam, you just press on share screen.
Share screen, I did it, and my PPT is actually on the screen now. But
No, madam, it must have got minimized. If you move your thing below, you will see it.
Uh, I think why don't you ask Rupali to present, not Rupali, next person to present
She
it.
has already finished, madam.
Okay, okay. This is share actually. I'm not
Madam,
able to
stop
get.
sharing. Stop sharing, please.
Yeah, yeah.
Have you stopped sharing? Stop share. Stop share. Madam, just stop
Yeah,
sharing.
yeah. Double clicking on that also is not going off. Yeah,
You have stopped sharing, madam, now?
yeah.
Okay. Now, minimize the zoom. Have you got the PowerPoint opened?
Yeah, PowerPoint is open.
Can you minimize and see if it is open, madam? Minimize the zoom. See if your PowerPoint is open.
Yeah, it is open.
Right. Go back to the zoom, ma'am, which will be minimized. At the bottom, click on the zoom. It will open up again.
Zoom is no. That is.
Has the zoom come, madam?
Yeah, Zoom is into the. Should I share? Make
Share
the size.
screen.
Yeah, yeah, yeah. It is. It has come, but I am not able to see. Are you able to see
No,
my?
madam, madam. You have not yet shared, madam. Press
Okay.
share screen. Then you have the boxes on the top. You have to
Mm.
click. You will see one place marked as PowerPoint. You have options of desktop, PowerPoint.
Google Drive, SharePoint, Microsoft Dropbox, Microsoft OneDrive, Box, Basics and Advanced. Files are there. Under the files, these things are there. The desktop.
Madam, yes, now we are getting it. 1 minute.
Mm.
Right. Now at the bottom, yes, madam. Click on that.
Yeah, now you are able to see my
Yes,
slides.
madam. Go to the first slide, madam. Yes, go to slideshow, please.
Sorry for the
No
really the
problem,
time
madam.
waste and
Yeah,
everything.
yes,
Yeah.
madam. Right, madam. Please go ahead.
Yeah, yeah. Good afternoon to everyone, and sorry for the all the waste of the time. And really, the other person made my life much more tougher, saying that really the females requires a different type of an exercise. So I am in favor of advising exercise for all. Actually, the cardiovascular disease is a largely preventable conditions except the non-modifiable risk factors. So the cardiovascular disease risk reduction is through the decreasing the smoking or stopping the smoking and the healthy diet and increasing the physical activity and avoiding the harmful use of the alcohol. So if you think about what is the additional advantages the regular exercise activity produces is, it is mainly, it reduces the cardiovascular the risk factors including the obesity, dyslipidemia, hypertension, metabolic syndromes, and diabetes mellitus. And in a case of the known CAD patients, is improve the angina-free activity and prevents the heart attacks, and the results in the decreased death rates. In patients with the heart failure, it improves the heart function and quality of the life is improved. In peripheral vascular disease, it improves the walking distance. So the regular physical activity benefits the human cardiovascular health either directly or indirectly. The traditional risk factors for the coronary artery disease, such as dyslipidemia, hypertension, diabetes, as well as cause of the mortality, are inversely correlated with the cardiorespiratory fitness. This is true for the males and the females. Benefits are independent of traditional cardiovascular risk factors. Physical inactivity is the fourth leading cause of the death. If you see the what are the other benefits other than the regular what we know the things or about by the exercise, it improves the vascular endothelial function mainly by increasing the nitric oxide levels and autonomic balance mainly in the favor of a decreased sympathetic activity and the increased vagal tone, and vascular remodeling it causes more in the favor of the angiogenesis. So it is causes the enlargement of the conduit vessels and causes the release more of the collaterals. If the plug is already is there, actually it stabilizes the plug and it prefers the cardiac preconditioning mainly by increasing the nitric oxide levels. So, as already told by Madam, there is some differences in the sex differences in the heart is present between the males and females. That the cardiac size and function differs men and women, and sex hormone levels are largely different between men and women. Both estrogens and testosterone are found in the both sexes, and androgen and estrogen receptors are found in the hearts of the men and women at comparable levels. So this is the table that represents mainly the what are the levels and what is the percentage of the differences between the men in and the women in a premenopausal and the postmenopausal state. Not only that, men and women differs when the pressure load problem occurs. Both will starts initially as a myocardial hypertrophy when the pressure overload is increased, but women stay more in the concentric myocardial hypertrophy stage with maintaining the systolic function, whereas men develop more easily eccentric myocardial hypertrophy. All said and done, the response to the exercise in the both sexes in the different cardiac diseases is, even though it differs, but the end results is going to be then a good effect for the male and female. Even though the presentation, the prognosis, and outcomes differs in the different cardiovascular diseases, both males and females have a good, effective improvement in the quality of the life, lesser cardiac and non-cardiac event rates. And I am not including the decreased mortality there because a few of the studies demonstrated. So I wanted to add that additional effect on the mortality subsequently. So these are the some of the studies which says that there is no difference in the men and the women to see the effect of the exercise. So actually, in general, there is underrepresentation of the women in all the uh, clinical scenarios, but I specifically I selected the only taken the men, only taken the female studies in the past 3 decades, so that it will be the much more effectively I can convince the people that the gender bias is not there when the exercise good effects are demonstrated. For example, you take the amorphit study, which is done in the purely in the men. In the leisure time exercise that reduces the cardiovascular mortality during a 16-year follow-up for the men with a high-risk coronary artery disease. Honolulu heart study done in the elderly men. These elderly men walking more than 1.5 miles per day reduce their risk of the coronary artery disease. Come to the females. Nurses health study in women. Walking was associated with a cardiac protection. And the lower study in a postmenopausal woman it was done. Moderate activity in the postmenopausal women are associated with a reduced risk of the cardiovascular disease. When CP et al. Study, it is done in the men, the people engaging in the regular exercise also demonstrated other cardiovascular benefits such as decreased rate of strokes and improvement in the erectile dysfunction. There is also a 3-year increase in the lifespan in these groups. So men and women differ in their exercise habits, but still, does this gender difference in exercise motives and habits differently affect the quality of the life and the health of cardiovascular health is doubtful. Awareness of the changes in the quality of the life due to the gender differences in exercise habits and the reasons for exercise could be advantageous for the health providers that prescribe the exercise program than the debating on whether the females requires or not, either differs or not. Then definite, as this is a basic one to give the information that the sedentary behavior is 1 to 1.5. So I need not to go through this chart actually. In addition to the what are the all the advantages told in the both in the male and females, another advantages are also is demonstrated in exercise. That is regular exercise being causes the shown to reduce the type 2 diabetes, some cancers, falls, osteoporotic fractures, and depression. And not only that, it is useful for the improvement in the weight management, cognitive functions, and enhance the quality of the life and decrease the mortality. These are the recommendations with an exercise in the physical activity in 2019, but this is not distinguishing whether the male and the females is required. In summary, I want to say, please advise exercise to all with modification of the general condition and the disease he or she is suffering than on the basis of the gender. Thank you.
That was very nice, Dr. Jyotsna. So, if I could make a comment in the beginning, I totally agree with what Dr. Jyotsna is saying, and let's specify the gender and sex are two different things. Sex is male or female, gender is how society treats you. And what Rachel is saying is actually a woman is reduced to, her looks or her physical and You don't see the benefit of metabolism being generated by exercise. And your approach is also, you don't need to do it. We are treated in society differently and not allowed to develop your cardiovascular. I mean, in South, there's a lot of dance. I think that's indirectly a wonderful way of exercising and developing the coordination and the proximal muscles. It's beautiful. That's a socially acceptable way. But this bias has to go, and the cardiometabolic benefits of exercise are there for everybody. So there's no question about that. And we are more on a scientific platform, not on a, on the just the social or the physical appearance platform, where we cannot. I would agree totally with madam. It is important, and we have to give advice to everybody. Women are inhibited. They don't develop their physical capacities the way they should. They don't maintain it, and they're happy pushing others and not looking after themselves. This definitely, I agree with madam totally.
Thank you all.
Madam, we are going to have to close this session as uh, we have overshot our time. So we thank all of you.
Thank you.
Thank you very much.